second in case they're struggling to get in. So Layla's going to introduce planets briefly, and then we have Tara talking first of all, who is a NET dietitian, very experienced NET dietitian that we've probably, a lot of you have met before. If you can't hear us, just pop something in the chat box and we'll see if we can help you, but I've had no messages so far, so that's a good start. Okay, so I'll pass you over to Layla.
Lovely. I think give it a few more minutes, because you know what it's like. Technology. Just to double check everybody's in.
So there are a couple of new patients who might not have seen us before. So on screen, there's Layla, who is Planet's CEO, and I run Planets with Layla. And we are also NET patients, so we might have a few questions too, quite long-term NET patients. Then there's Emma on the screen, who most of you will know as well, and Emma is the CNS at Southampton who looks after us all.
Hi there.
Hi Helen. Got the chat box starting, so feel free to chat throughout. It's nice to hear from you, and it's nice to know you're all there and listening. So you can disappear and make a cup of tea whenever you like if you're online, because we don't know what you're doing. So if you're in your pajamas, don't worry about it.
We can't see you falling asleep. Like Parliament, isn't it?
You can also leave at any point as well. So if you've got to go to work or anything like that, don't worry about popping off. This session is being recorded, so after it's finished, I will upload that onto YouTube, our YouTube channel, and then I'll share that as well. So you can rewatch, revisit anything, or pass on to a patient that wasn't able to come. So we've got almost everyone in the room now, Layla, so I think we can get going.
Okay, we'll crack on. Hello, everybody. I'd love to say it's nice to see you, because I can't see you at all, but it's nice that you're all here. Thank you for joining us in these funny times that we're having at the moment. I'm having a funny time this week because I've just had surgery, so excuse the face, the tired, worn face. And we'll be definitely falling asleep this afternoon after this morning, but lovely that we're all here together and we can have this conference as we do normally, face to face, but it's got to be virtual this year. I'm praying and I'm hoping that next year we can actually get back down the hotel and see each other and be rid of this last 2 years. But for now, this is the way it is. For the new patients that are in the room, hello there. It's nice to meet you kind of in this way. I hope you're getting all the information and all the advice and all the guidance that you need at the moment. Hopefully this will come some ways to help you understand NETs, etc. And Q, I've just had a flush, just had a coffee. That's my trigger for my carcinoid flush. That's the first lesson. Always happens on my morning coffee. So planets for the new people in the room, and I apologise for everybody else that's heard it a million times over. Planets was formed back in 2000, about 10 years ago, back in 2011. And it was formed by Neil Pearce, who was then a surgeon, and Brian Steadman and myself and a couple of other fundraisers. And we really didn't think it was something small at the time, and we were focusing on neuroendocrine patients and pancreatic patients. And it was, at the time, it was just something we wanted. Our goal was to fund a scanner for £70,000. We reached that goal and it just snowballed. And the way we work is, as a charity, we work closely with the hospitals, with the staff, being formed, with hospital staff. I think that makes a big difference as a charity. We've just gone from strength to strength, and we've really kind of almost, we didn't really know what we were doing in the beginning, I'll be honest, and it was more about shaking things and collecting cash and trying to fund bits of kit. But over the years, we've moulded and we've formed something that's grown quite rapidly. And to date, we've raised over £1.3 million. That's over 10 years. So just going from that £70,000 scanner to now is incredible. We've issued, we've set up patient support groups, patient conferences, and that's not just for NETs, that's for colorectal and pancreatic and liver as well. We've got conferences, we've got a whole wealth of social media, Twitter, Facebook, and there's a Facebook group. So for those new people that are listening, there's a Facebook group that you can go on and ask questions, and we're a lovely community. We call ourselves the Planet's Family, so hopefully that will help the new people in the room. We've done lots of small things. We've given models of pancreases to Portsmouth Hospital, Bournemouth Hospital, Southampton Hospital, and we bought great big bits of kit, which one is an IORT machine, which is used in theatre, which is worth over £2 million, but obviously we've been lease purchasing it for a much more discounted cost, and that's been one of our biggest burdens. But we've also been working on research and development. We had a joint funding research project where we funded some NET research, and we've also funded a dietitian post, and we've also set up psychotherapy sessions, which hopefully we'll get back into the groove and starting to do those again next year, along with actual physical meetings. In the meantime, what we're going to do to keep within sort of what I feel is more comfortable rules with COVID is we're going to have coffee mornings. So, a few people getting together around the areas, whether it be Dorset or Hampshire, Southampton, Portsmouth, to be able to get together and see each other. Certainly for the new patients, I think that's really important. A lot of the patients that have been to this conference and known us for many years, that we all know each other, so there's a lot of linking up separately. But for the new patients, I just want them, want you to be aware that we're here for you, although it doesn't, might not feel like it, we are here for you. And if you want a one-to-one, that's fine. If you want a coffee morning, and then we can build up the confidence, because I know not everybody likes to be put into that position, certainly not when you've just been diagnosed, because it's a massive roller coaster, being diagnosed with neuroendocrine tumors. So we, alongside all of that we've done as a charity, we've also contributed. One of Neil Pearce's main goals was, when I back years ago, was that he always wanted to be a centre of excellence, always innovative, and always wanted to be the best of the best. So we applied for that. The hospital applied for that. I think it's about 5 years ago now, and we got that Centre of Excellence award. And then when more recently it had to be renewed, and so I was luckily enough to be a part of the group that were being evaluated from all over Europe. It was all on Skype, obviously, and we were being evaluated, and they went through all the doctors and nurses and everybody did their part, did the presentations, and it was outstanding. And I've seen these people talk for many years now, and I was just, even watching them and give their presentation, which I probably have seen many times over, I just was filled with a massive sense of pride, and it was unbelievable. And when I gave my presentation, I made it quite clear that it really didn't matter to me, because I knew exactly how good this team of people were, and it was lovely. And the evaluators went out the room, so we were all watching on the screens like you are now. They went out the room, and then we were all sat there, and I've never seen a group of top amazing world-class medics being so nervous in my life, and so was I. And we were all sort of a bit quiet and not really saying anything. And then the evaluator, the chair, walked back in the room and said simple words of, we just want to say what we've seen is absolutely excellent, and it's one of the best presentations for the Centre of Excellence, the NET Centre of Excellence, that we've ever seen. So that, for me, on top of everything that's happened to me personally and for this charity over the last 10 years, was just amazing, and just so grateful for everybody that is a part of this team. And yes, we do, for those patients that are watching that might be referred from other areas, because I know we've got a few that are being referred at the moment from all over the place. That does include you. You're part of this team, and we're always here for not just our regional area, which is the Hampshire and Dorset and areas, but across across the country, and we do have lots of referrals for that as well. So we know how lucky we are. We're a very friendly bunch, and it's been a really difficult year, 2 years. As a charity, I was concerned because I thought that we wouldn't survive because fundraising went so low. Fortunately, we had the opportunity to have a BBC campaign that went on the television and which covered us. We also had a grant from the hospital, one of the trusts, and that has actually put us back on our feet. And then more recently, we received a legacy for over £300,000. So we are, going from the middle of COVID, where I thought I was actually having to close down the charity. We're in a completely different position now. The future is really bright, and hopefully we can continue to build and build on a lot more things and things that we really want to do. Jo and I have always been a bit reactive when we're running this charity, and our aim for 2022, our New Year's resolution, I think, Jo, for 2022 is that we're going to be a lot more proactive. So watch this space on that one, and fingers crossed we can get back to some kind of normality. But that's enough for me because I'm going on. So for today, thank you for everybody that's speaking today. I've been to 10 of these now, at least, and I still find something interesting and still find something new. So I hope for those of you new and old that are used to these conferences, I hope you enjoy the day, and I will see you all hopefully very soon. And so if I pass you straight on to the awesome Tara, who will be doing a presentation for us. So hello, Tara. Who'll be doing a fantastic presentation for us today. I've got a few.
Hello. I hope you can hear me.
Absolutely, we can. I've got a few questions of my own, actually, post-op. So
thank you for the overview and the update, because I haven't seen you all for a few years, and I used to come down and see you, and it's probably been 3.5 years or something.
Yeah.
So it's nice to hear what you're doing now. I know I kind of keep up to date with Facebook and things, but I saw you had a nice ball.
Yes, brilliant,
really good. Really
excellent. Good. All right, so I've got 20 minutes. I've got loads to pack in. Those who have seen my presentations before, it'll all be familiar, but for those new, hopefully there's always something that I can talk about that's interesting to everyone. So let me just share my screen. Okay. All right, so the subject, obviously, as I'm a dietitian, is dietary hot topics. So basically, neuroendocrine cancer and its treatment can lead to a variety of complex nutritional problems. So many of you will know that already because you've experienced them already. And sometimes it's further down the line, depending what kind of treatment. So there's multiple causes for nutritional problems and why a dietitian is so important to the team. So it can be the cancer itself. So maybe it's the hormones that it secretes and the peptides, or that the cancer has obstructed part of the intestine, or this desmoplasia, which is this fibrous scar tissue that grows around. And then there's problems like the tumour causing cachexia, so a large proportion of muscle loss compared to fat loss. And the surgery, so if you remove a part of the bowel or an organ, then you remove the capacity to absorb sometimes, or the organ itself may be making something that was needed to help digest. Then there's the medications and the treatments. So these can often lead to malabsorption, and if they make you feel poorly, then your intake might be lower for a while. So first up then, so loose stools. So when we say, have you got diarrhea? Have you had diarrhea? What's your normal bowel habits? Most people will often have a loose stool, even if they don't have a neuroendocrine cancer. That's normal. We all go up and down in that respect. Loose stools that are common in this area of cancer really varies, and there's so many different types, and it's very important as a dietitian that we know why it's happening. So it can be hormone and peptide secretion, as I mentioned before, if your tumour is functioning. It can be pancreatic exocrine insufficiency, so where your pancreas isn't making enough enzymes. It can be pellagra. A side effect of niacin deficiency is this condition called pellagra, and this causes diarrhea. There's bile acid malabsorption, which we shorten to BAM, and bile acid deficiency, and this is like an acidic burning diarrhea. Small intestinal bacterial overgrowth. There's overflow diarrhea, so where you've been bunged up for a while, even constipation or bowel obstruction, then you get this rush of diarrhea when it all seeps out again. Hyperthyroidism can cause diarrhea, that's often overlooked. You can also have inflammatory bowel disease. We have some patients with inflammatory bowel disease or celiac disease, as well as an intestinal tumour. IBS, obviously lots of people are diagnosed with that before they get properly diagnosed with the cancer, and then things like food poisoning. So pancreatic exocrine insufficiency, so some of you will know about this already. So it's where the foods, the fat, carbohydrates and protein are insufficiently broken down when you eat. So this can happen in all different types of pancreatic cancer, after pancreatic surgery, where you remove enough of the pancreas for it to be affected, and with the use of somatostatin analogues. There are other conditions like cystic fibrosis who need the enzymes as well. But basically, if you're not absorbing your food as normal, the first thing that we often see can be weight loss, but then it follows with fat-soluble vitamin deficiency if you're not absorbing your vitamins. So we use our enzyme replacement, and it's often a brand like Creon. And then if that kind of doesn't help too much or it causes side effects, then we can swap the brand. And there is a question mark whether we should test for this first. I think the consensus now, rather than using fecal elastase testing, would be to actually just start enzymes when we start a somatostatin analog treatment, and then see how
I can't see your screen. I don't know if anyone else can see your screen, but Emma said she can't see it either. So.
Right.
Definitely given you the sort of option to share. Oh, it looks like everyone else can. Maybe it's just the panelists that can't. That's great then. Okay, that's fine. Carry on. If patients are happy, that's great. Sorry to interrupt.
Are we sure?
Oh, Sharon has said I can't. How strange. Oh, there you go. I can see it now.
Yeah? Yeah. So some people can. That's weird. Okay, right. Let me.
And everyone else is saying they can see it as well. So, okay.
Could everyone hear me at least?
Yes, we could all hear you. Sorry to interrupt.
No, it's all right. No.
Everyone's saying yes now, so that's perfect. But yeah, I would just carry on from where you were, because we could understand everything you're saying. It's just we didn't see it.
Okay.
I'll shut up.
No, that's good that I know. Yeah, I think I finished that slide. I'm just going to move you all to the side so I can't. Yeah, okay. So in terms of the enzymes that we use, the only medically tested enzymes are from a pig origin, so a pig pancreas. It sounds a bit weird, and people are often a bit scared about putting something from a pig to digest their own food. And obviously there are always concerns about religion and whether they can have pig products, but they all are approved by religious establishments anyway. We only use the medically tested enzymes rather than what you can find in a health food shop or on Amazon, because they are medically tested and they are gastro-resistant, so they don't break down before they get to the area that they need to. There are papaya enzymes, pineapple enzymes, all these things that people often want to have because they sound nicer, but we don't actually know that they work at all. They're often in low doses of lipase, which is the key number that you see on the label. And this needs to be quite high, because if it's not high enough, it won't break down the fat and you'll still get this loose stool, which is a yellow steatorrhea. It's not moving forward. Okay, so this dosing should always be under the care of a dietitian. As I said, we start with Creon. It's the cheapest. Still not cheap, but it's just cheaper than other brands. The starting dose is 25,000 units of lipase per snack and 2 per main. And then we titrate this up. And as symptoms reduce, so loose bowel movements reduce, then we kind of find the right dose for you. The general rule is the more fat you eat at a snack or a meal or a smoothie, or a substantial drink, then the more of these enzymes, the PERT, that you need. So the maximum dose is 10,000 units of lipase per kilogram of body weight. So if you were 70 kilos, that would be 700,000 units of lipase per day. So often people say, oh, they're not working, I want to stop them. These enzymes are not from a human, they're from a pig, and they're not as good as our own. And we shouldn't expect them to be exactly the same. So therefore, we need to make sure that we can help them work as best as possible. So we give half a dose with the first mouthful and halfway through the meal. If you were to have 3 for a main meal, you'd probably have 2 at the beginning and 1 halfway. This is just so it opens up in the small bowel and it starts mixing with the food. It starts breaking down the food nicely. So by the time it gets further down the bowel, then it's nicely digested. If you take it afterwards, you might be in trouble because it has to catch up with the food. It has to then mix a bit later, and it might be too late, and you may still get this steatorrhea and wind and pain and things like that. Often people forget when they go out for a meal, so it's important to take a little pot with you. And if you're having dessert, you need to take more. So we need to check that you are taking it correctly, you're taking enough. If those 2 things are okay, then we would look at starting a proton pump inhibitor. So this reduces the acid. It is an official recommendation to try it, although the Creon company don't acknowledge this. They say you don't need it. Is actually within the guidelines that you should try a proton pump inhibitor first thing in the morning before your breakfast, half an hour before, and that really helps things work, and also any loose stools down as well. And then the correct timing of the PPI, so making sure that that's not halfway through the day when you're having all your enzymes all at the same time. It needs to start working itself before you have the enzymes. Okay, so on to the next section, so slightly linked, so fat-soluble vitamins. So fat-soluble vitamin deficiencies cause a variety of health problems. So the side effects of being deficient vary from night blindness and osteoporosis to bleeding and dry skin. So in a global survey of patients on somatostatin analog treatment, 51% of patients reported that they had at least one type of deficiency. That was I think it was a Survey Monkey or something that we did a poll a few years ago, and this was some patients from around the world. They were probably mostly vitamin D deficient, but at least 51% of patients had one type. We then followed this up with an actual study in our patients when I was at the Royal Free Hospital. We had 66 patients on somatostatin analogues, and we found that 47% of patients were deficient in at least one of the 4 fat-soluble vitamins. So these are vitamin A, D, E, and K. So onto a different vitamin, so niacin and pellagra. So vitamin B3 is called niacin, and this deficiency can occur from Carcinoid Syndrome. So most people don't have Carcinoid Syndrome, but for those who do, it's where the serotonin is pumped out of the tumour and any metastases. It especially happens once it's gone, travelled to the liver. Symptoms become much worse. We know that 28 to 45% of patients, when they're first diagnosed, have a deficiency or a low level of niacin. That was an American study. We don't have a UK study for that, actually. And we know that we can prevent it, and we know that we can treat it because it's a vitamin. So we are writing guidelines at the moment, but the prevention is roughly 50 to 100 milligrams a day of nicotinamide. And the treatment, if we think you have pellagra, is 300 milligrams a day for a month. And these are in split doses throughout the day to avoid too much of a flush, which is a side effect of nicotinamide. So that's how we prevent and treat. And just in case you're wondering how I would know whether you have this pellagra, it shows in different areas of the body. So the skin is affected, so you can have these different lesions and kind of rash effects. The mouth is affected by inflammation, and the intestinal tract, so diarrhea, and the central nervous system, so dementia. So we always say the kind of 3 Ds are dementia, dermatitis, and diarrhea. And the 4th one, actually, which won't happen in this patient group, is death. But if you don't treat niacin deficiency and pellagra, it will lead to death. So it's just important that people recognise that it does exist. So syndromic diarrhea, so where we have a functioning tumour and it's the peptides and hormones that are causing all this problem. So we have carcinoid syndrome and obviously other syndromes, especially VIPomas, which is very, very high amounts of fluid loss through diarrhea when it's uncontrolled. So the carcinoid syndrome dietary triggers, I'm sure people have seen, different lists from around the world, should I exclude tomatoes? There are different exclusion lists. Don't get this confused with the urine tests, the list that's given to you before a 5-HIA urine test or blood test. And these are the triggers for a flush and sometimes also diarrhea. It's important to note that carcinoid syndrome diarrhea continues with or without food. It just happens. It might be made worse with food. The more you eat, the more diarrhea you will get. However, it will still continue. So starving yourself isn't a good idea. There is a theory, and I say theory because we don't actually have any proof, but high vasoactive amine foods or drinks were noted quite a while ago in the US to trigger symptoms in a small proportion of people and cause this obvious carcinoid syndrome. And I have recently come up with a diagram and a theory, which I was going to show with you, but actually probably shouldn't because it's not released yet. So watch this space, but there's a variety of things that can cause a flush, like stress, like waiting for a scan, like waiting for your appointment, worrying, anxiety, standing up, going upstairs, but also food can trigger a response. So these vasoactive amines are the same things that are triggering some people with migraines. And these are like the cured meats, processed meats, processed fish, the moldy cheeses, the really aged old cheeses, not the fresh ones. Some fruit can cause an issue. Tomatoes is on there. And I know sometimes people wonder why it's on there, and the other 24-hour urine exclusion list as well. Some people do react. Then we've got fermented soy proteins and all those kind of Japanese foods. And the drinks are important because people often think that they must be okay, but they're not. So Layla, we've got coffee. Green tea, champagne, chocolate wine, beer, fresh fruit juices, smoothies. Unfortunately, apart from green tea, they're all pretty nice, those. So that's it's a shame if you do react, but just to note that if you are reacting to foods, or you think you are, you need to speak to the dietitian. You have to use a food and symptom diary to really know that it's that, because you'll only react within an hour or so. If you react after that, it's probably something else. You could just be stressed or something. And it's only avoiding things that you know are a trigger, rather than avoiding everything on that list, because then life might be a bit unhappy for you. Note that alcohol can include the vasoactive amines. So yeah, just watch that list of champagnes. Actually, things that are brewed in an oak barrel are worse than a metal one, funnily enough, so you can look out for that kind of thing. And if you have really, really bad fluid loss through uncontrolled diarrhea, obviously you might have different medications from your team, but you have to replace that fluid and the salts that you lose. So we use like Diarrhelite or double sachets of Diarrhelite if it's really, really severe and not controlled. So the last or second to last type of loose stool is bile acid malabsorption. So there's 3 different types of bile acid malabsorption. I'm just checking the time, seeing how I am. Okay, yeah, I'm running over already. So there's 3 different types of bile acid malabsorption, type 1, 2, and 3, which you can see in front of you. And basically, we treat bile acid malabsorption with a bile acid sequestrant, so it's often a sachet or sometimes a tablet. And we use a low-fat diet in some patients. However, if someone is on the low weight side, then we wouldn't go straight to a low-fat diet. We'd try and maximise the bile acid sequestrant. And these bile acids that you're not absorbing are bound with these bile acid sequestrants to stop you having this acidic diarrhea. If you are on bile acid sequestrants for a few months, you can get this deficiencies in the fat soluble vitamins and other minerals as well. So the guideline is that anyone on Questran or anything like that should be tested for the fat soluble vitamins at 3 months and then yearly. Obviously at 3 months, if they're low, then they need to be corrected at the time and then tested a year after. And then the final type of loose stool, small intestinal bacterial overgrowth. So we have people, hydrogen exhalers, which are tests which exhale the hydrogen, are often people who have diarrhea predominant symptoms, and methane exhalers often have the constipation predominant symptoms. We don't have any proven dietary interventions yet. However, we do play around with probiotics, low FODMAP diets and meal gaps. So starving the gut from food to kind of try and treat alongside antibiotics and things. There's work in fecal transplants, so where you're taking healthy poo out of a healthy person and transplanting it into someone with a gut dysbiosis where not so healthy, and it's freeze dried, put down a tube so you don't taste it, and then put into the small intestine. That has very good short-term effects, but not long-term effects. Obviously, if you're having any type of loose stool, we need to monitor vitamins and minerals as well. So I'm not too far over, but just to mention that we are writing proper nutrition guidelines at the moment. They've been going on about 3 years. I started them 3 years ago, and we're collaborating with dietitians around the world, and they are guidelines for health professionals to follow so we can start improving. You've got a brilliant site, but other hospitals do struggle with nutritional care, and it's really to raise standards and raise, we have, I personally have quite high expectations for nutritional care, and it's just to make sure that nutritional care is improved globally, really. So I don't know whether we have any questions.
Thanks, Tara. So there's a Q&A box at the bottom for anyone that has any questions for Tara. I've got one actually, and I mentioned it to you briefly yesterday. So yep. I take Colisevelam for, if I'm pronouncing that right, for yep. Since I've had no gallbladder, I've had some issues, which absolutely does the job, as long as I remember to take them. But I also take various sort of supplements and vitamins and things just to kind of address any issues that I might have there. I always wonder how I should space things out. I take Colisevelam 3 times a day, so that kind of makes it quite difficult to find slots to take other bits as well. Does it matter if you take your vitamins at the same time as your Colisevelam, or are you just cancelling things out by doing that?
It's funny because on our guideline call on Monday morning, we were having this discussion whether we don't have any evidence that it happens. However, theoretically, I would say you don't want to be gluing anything to the Colisevelam. So that's, you wouldn't eat at the same time. You wouldn't have your vitamins or medications. I think probably those companies would say, you can, but I think if you're worried, or if you want probably I hope you can hear me, it's gone a bit weird. If you want an exact answer, I'd speak to the pharmacist, but also read, because different companies will give different advice on their on the inserts, the medical prescribing information within the box or pack that you have.
None of my blood tests have ever returned that I'm deficient in anything, so seems to be okay, but I don't want to be just taking vitamins, all these expensive things you buy and stuff for them just to be kind of passing through with no impact, I guess. So ideally you would just take them at different times.
I think the best thing to do would be to take your vitamins and minerals during a meal, because they're all then processed together.
Okay, that's useful information. Thank you. Has anyone else got any questions before we let Tara go? Because I'm going to bring Salma into the room in a second for our next presentation.
I've got a couple, sorry. Does it matter on the coffee side, obvious selfish reasons asking, whether it's decaf or caffeinated?
So
is that the trigger?
Can you see me?
Yes.
You can? Oh, okay. So high doses of caffeine are an issue in terms of stool movements, and they often get pretty much everyone to pass a stool, and they're quite good for constipation. But The vasoactive amines are the things that cause the flush, and I think probably even decaf would cause that as well. We don't actually know whether the flush is harmful to you. It's a sign that something's happening, but we don't know whether these dietary related flushes are harmful. So yeah, I always say if you don't mind, you know, having the occasional flush, then, you know, it's fine. Just have it.
I've been having it for 13 years, it's fine.
Yeah.
I've got my first ever deficiency, so that's my next question. My first ever deficiency in 13 years. I'm anemic, apparently. So I'm going to be put on ferrous sulfate. What implications is that to my disease? And what would you suggest?
So iron deficiency is the most common deficiency that we see. I didn't talk about it, but I didn't have a chance. You know, it's very common that your iron goes low. Your ferritin stores, your iron stores are what we look at and see whether you've got any reserve to boost your hemoglobin and everything in your blood. In terms of the implications of anemia or iron deficiency anemia, it's tiredness, fatigue mainly that will affect you. But when you start the treatment with this ferrous sulfate, then you can get these black tarry stools and slightly more constipated while you're on the tablets. Normally you wouldn't have to be on them for more than a few months. But if you're taking these tablets then to help absorb the iron and get your levels back up, you should really have a vitamin C containing drink or fruit or something while you have the tablets, just so they're absorbed better.
Okay, thank you, Tara. I look forward to constipation. Really do look forward to that. Sounds mad, but it really is one of those things. And the last one, sorry, it was a subject that was picked up on the Facebook. You know, I've not seen many patients complain about this. I am a complainer of this. Low blood pressure. So somebody mentioned it on Facebook. Can you recommend anything at all for low blood pressure?
Well, drinking enough fluid, obviously caffeine and things raise your blood pressure, salt will as well. It's just knowing when it is low. If it's permanently low, then you know you definitely need medical treatment for that. It's often to do with the kidneys. So yeah, from my point of view, is having enough fluid, have enough salt, and caffeine can temporarily lift you, but it's a bit more difficult low.
Okay, thank you, Tara.
All right, thank you.
Yeah. Oh, can I just reiterate what Mark said in the chat, if anyone hasn't seen it, with the colesevelam, you know, especially if you're on cardiac meds and stuff, there are really strict guidelines around when you should take your colesevelam in relation to other meds. So just speak to whoever's prescribed it for you, just to get the actual guidelines for you with all your other medications and whatever else is going on with you. And then also about the low blood pressure, if you feel that you've got low blood pressure, make sure you speak to one of us or your GP.
Okay. Thanks very much, Tara. That was really interesting. I don't think we've got any other questions. So Salma is in the room now. So oh, hang on, we've got a question. Got a late question. Can you see that, Tara?
Yep.
And Emma.
Colesevelam with Creon, as they both need to be had with food. Does Colesevelam? Yeah, this is the conversation that we were having. I think half the dietitians said it probably is okay, but again, it's more of a pharmacy question, to be honest. We do get asked these things, but the pharmacist really should be the person to answer that one. Okay,
thank you. We better let you go, Tara, because I know you've got work to do before your trip, and Salma is in the room as well. Thanks so much for joining us. It's really great.
Thank you.
Okay, so I'm just going to bring Salma in. So
can you hear me?
We can hear you, and we can see you, and we can see your screen as well. So that is a good start. Thanks, Salma. I'll pass over to you.
Just give me 1 second. My computer seems to be having its own issues on this end, so trying to see what it's actually doing. Just give me 2 secs. So there we go. Can you all see my screen?
Perfect.
Excellent. So hello, I'm Salma. I'm one of the medical oncologists at Southampton. I work with Judith Cave and Luke Nolan as part of the medical oncology team. And I'm going to be doing an overview of neuroendocrine tumours. And I think the title I was given was, what are neuroendocrine tumours? So we'll have a bit of an overview rather than going into detailed specifics. So this is when it doesn't decide to share. There we go. Okay. So what I'm going to cover today is what is a neuroendocrine tumour, the classification of NETs and the different ways we can do that, how common are NETs, some of the causes of NETs, staging and grading, teams that will be involved in your care, potentially not for every patient, the types of scans we might consider, and the types of treatments that might be involved as well. So neuroendocrine tumours or cancers occur when neuroendocrine cells stop working normally and start to grow and or behave abnormally, much like other cancers. But there are kind of several different types of NETs, and the type you have will kind of depend on the type of cell that the cancer originates from. So confusingly on this topic, just to make you very confused about a rare cancer, there are multiple different terminologies that you'll find depending on the type of cancer you might be dealing with. So there's neuroendocrine tumours, there's neuroendocrine neoplasms, neuroendocrine carcinomas, and a lot of that is technical jargon that oncologists and other people from the multidisciplinary team use to help us classify these types of tumours. So they're all kind of part of the same broad family, if that makes sense. So what is the neuroendocrine system? So the neuroendocrine system is made up of nerves and gland cells. So our bodies are basically made up of billions of cells. Each has their own appearance and function. For example, you have blood cells or bone cells, and then likewise you also have neuroendocrine cells. And neuroendocrine cells are present throughout our bodies, and they create a network that keeps us well, essentially, by monitoring what's happening within our bodies and communicating with each other to release specific substances such as gut hormones and or peptides to help our bodies function normally. And this network is called the neuroendocrine system. So specifically, what do neuroendocrine cells do? As we've just discovered, we've got multiple neuroendocrine cells throughout our body, and I've listed this picture is meant to show the most common places. So your GI tract and your pancreas, your liver and your lungs are the most common places where you find neuroendocrine cells. And they have different functions depending on where they are in the body. As we've said, in the stomach or bowel or lungs. And what type of hormones neuroendocrine cells will release will depend on what part of the body they're in. For example, in the digestive tract, they'll produce hormones that help to break down our food in our gut and move food through the small and large bowel. And that helps both with nutritional uptake and eliminating waste. And that's why you can sometimes get the symptoms you do of diarrhea, etc. and weight loss. In the respiratory symptoms, they produce hormones that help with the development of our lungs and to regulate our breathing, and sometimes you can find that patients develop breathlessness, etc. So very much dependent on what type of cells are affected. So just moving on now to the classification of NETs. Historically, if we look at this picture over here, we used to call these NETs, or we used to divide NETs or classify them into foregut, midgut and hindgut. And that was basically based on the presumption that neuroendocrine tumours arise embryologically from the neural crest. I'm getting into medical jargon now, so I'll try to pare it back. And so that's how they were kind of divided into fore, mid and hindgut. But actually the reality is that they probably arise from the neuroendocrine cells from the various different sites, as I've just said. So using an anatomical description or classification is probably most helpful. More than 50% of neuroendocrine tumours arise from the GI tract or the pancreas, and about a quarter from the lungs, and then elsewhere in the body account for the remainder. So it, like I say, it's a very heterogeneous group of cancers. So talking about another way that we might describe or kind of classify these tumours. So you can describe them as functional or non-functional, and sometimes they're called syndromal or non-syndromal, depending on what preferred terminology is in a specific site. So some neuroendocrine tumours, they can secrete extra hormones, and those can cause symptoms. And these are basically called functioning tumours. And those that don't are called non-functioning tumours. The most common functional syndrome is called Carcinoid Syndrome, as we've heard about. And the symptoms of that include flushing, diarrhea, weight loss, abdominal pain. You might collapse sometimes, and in rare cases, your blood sugar can become problematic. And the reason why we worry about carcinoid syndrome particularly is over many years of kind of overexposure to the hormone serotonin, your heart can start running into problems. So you can start developing valvular problems, or it can affect the right side of your heart as well. So that's why it's very important that we kind of classify these tumours and work out whether they're secreting anything or not. So how common are NETs? So overall, NETs are rare. So approximately 4,000 people are diagnosed with a neuroendocrine tumour each year. If we compare that to lung cancer, for instance, about 50,000 people are diagnosed with lung cancer each year. So it's quite significantly less, and that brings its own challenges when we're looking at treatments and research and things like that. Because when you're dealing with when you're dealing with a rare cancer, often there's less evidence upon which we base our treatments, and there's more room for different modalities of treatment, essentially. Neuroendocrine tumours are becoming more common across the world, and in the UK, and we don't really know why. I think a certain proportion of that is definitely down to the fact that we've got better scanners, and so we pick up more incidentally. But it's not 100% clear why we're seeing these rises, and that's something that's still being worked on. Neuroendocrine cancers or tumours can occur in patients at any age, including in children, but the average age is around 50 to 60 years for diagnosis. What causes NETs? And this is something that people often worry about. But what we know is that we don't really know what causes NETs. We know that most cases kind of arise sporadically, so it's not generally something within your genes, but there are a small proportion of patients. So in a rare cancer, there will be a rare population of patients who may have a more genetic susceptibility, but generally speaking, they are they arise sporadically, so they're not related to your genes per se. So staging and grading, I'm going to move on to now. So this is one of the most kind of discussed things probably on forums and things, and sometimes it can be quite confusing, kind of working out what's the difference between staging and grading. So I thought I'd spend a little bit of time on that. And so mixing them up is quite a common error. So we'll just talk through that. If my screen will move on. There we go. So staging, in the most basic terms, is the extent and spread of disease, and it's usually diagnosed through imaging, and it will vary according to the location of the neuroendocrine tumor and also the country that you're in. So it will be different if you've got a pancreatic net to a lung net, but overall, generally pathologists and radiologists and clinicians are guided in terms of staging by the World Health Organization staging criteria, depending on the different site. And it's usually provides a kind of a useful benchmark, and it uses a system of 4 stages, as most of you probably know, 1, 2, 3, and 4. Grading. So if we just move on to grading. So included within kind of the grading of a tumour is a concept of differentiation, which I'll also talk about. But first of all, in the kind of, again, the most kind of basic way that I can think of it, grading is about how quickly cells are dividing to form new cancerous cells. And one important way that we do that in GI nets, so gastrointestinal nets, is by looking at something called the Ki-67, which is a stain we use on the slides from your tumour when we take a biopsy or take a resection specimen, etc., at surgery. So if I show you, hopefully you can see my pointer, this is a low-grade net. The brown dots are the ones that have stained positively for the stain called the Ki-67. And that indicates that these cells are the dividing cells. And so not very common here. And what we do is we get our pathologist to sit there and count 2,000 cells, and they very unhappily probably sit there and do it very patiently. And then they work out a percentage of how many cells are dividing or not. And then intermediate grades, you can see there's a few more cells that are dividing. And then in the higher grade nets, there are more cells that are dividing. So those are called the higher grade. Differentiation is another thing you might encounter. So we might say, a tumor is well differentiated or moderately differentiated. And what this kind of refers to is the extent to which the cancerous cells look like or resemble their normal healthy counterparts, the normal healthy cells that they're meant to be. So cells that are well differentiated will be ones that have the similar kind of structure to those normal neuroendocrine cells, but they might have started to change slightly in size or shape. They can become a bit irregular in how they're arranged, but cells which are poorly differentiated, which is another term we might use, have become more abnormal in shape and size, and they have a much more irregular arrangement. So symptoms of neuroendocrine tumors. So you guys are probably, experts at this. Neuroendocrine tumors often don't cause symptoms, although not in every case. And some, a lot of the times we find them by chance through looking for other things. But in a minority, in a significant number of patients, we know that they can have symptoms over multiple years. And because they're non-specific symptoms, often we end up misdiagnosing patients. And so it's not uncommon for patients to tell us that they've been to multiple different appointments, seen a number of different number of different GPs or specialists, and we haven't come to the bottom of it. And eventually it comes to light that we're dealing with a neuroendocrine tumor. So in the digestive system, you can get kind of tummy aches or pains, you can get sickness or diarrhea. So whereas in the lungs, you might develop chest infections or shortness of breath. as I've said before, NETs can sometimes make too much of certain hormones, and the type of hormone they make depends on the gland the tumour is affecting. So here is a diagram that I tried to make up. I tried to fill it up with more people, but the computer wasn't really having it. So this is kind of who's involved in looking after the patient. So the patient's always the centre of our at the centre of our approach. You'll have people like Emma and Mark, who are your clinical nurse specialists and probably the most important people. Then you've got the surgeons, the radiologists, and they can be divided into those who help us with the diagnostic side of things, and the interventional radiologists who perform procedures to help control cancer if needs be. Pathologists who have the job of looking at the specimen. It's really important to have a really good pathologist because they can make a big difference. Oncologists are obviously really important because I'm one. So medical oncologists generally tend to deal with systemic treatments, whereas clinical oncologists tend to deal with radiotherapy aspects of things. The gastroenterologists help us manage kind of hormonal side of things as well. And our important friends are dietitians, also very, very important in looking after our patients. And then you also have the endocrinologists and the nuclear medicine team as well. And this is by no means complete. There are lots of other people who are involved in different patients' care, and it will very much be individualized based on what your needs are at any given time. So whoever your consultant physician is may recommend you go off to see somebody else, and that may be for very good reasons. So investigations, and I've just kind of gone through a broad overview of the type of investigations we might use. So things like blood tests, so we might do our routine bloods to check the kidneys, liver, etc. And then we may do more specialist blood tests, which include kind of gut hormones, for which we might make you fast, chromogranins. I've forgotten to do urine tests. Sometimes we ask you to collect your urine to look for particular hormones. Then we're looking at radiology, so looking at scans essentially, and the way we can do that is through CT or MRI scanning, but we can also look at what we call functional imaging, and this is particularly to see if there's this particular type of receptor, the somatostatin receptor, because that may enable us to have different treatment options available to us. And then PET scanning as well. The echocardiogram is usually to check the health of the heart. And as I've mentioned, we like biopsies because that gives us much more information about the nature of the beast that we're dealing with. So that will tell us what type of tumour it is, and we can also work out how active, what the grade of it is through that, and the differentiation. Treatment, and again, this is an overview. There are a number of different treatments available for neuroendocrine tumours, and this will generally be based on your overall health and your choice and the symptoms that you're experiencing at a given time. The only treatment that is curative is surgery currently, and survival in neuroendocrine tumours is generally measured in years, and the treatment options that we generally have available to us are slightly different than that of standard cancers. Chemotherapy is much less used in these types of tumours, although it is an option. And in the more advanced setting, the aim of treatment would be about controlling symptoms, preventing or trying to slow the cancer growth, and extending survival and quality of life. And sometimes that involves surgery to try and take away bits of tumours, because we know that at least some of these tumours are slower growing, but there are other procedures that we might recommend, or other treatments that we may recommend, depending on depending on your particular case. So it's a very case-based, which is why it's difficult to go into specifics. Any questions? So it's probably quite quick, and I can't see the chat.
Thanks, Salma.
Yeah.
It's a great overview and really useful, especially for new patients. You've just got a question in the chat that is from a patient who's asking, why is chemo so rarely used?
So the reason why, chemotherapy is a systemic treatment, so it goes all over the body and it targets rapidly dividing cells. And as we've seen, if you've got a very slow growing tumour, chemotherapy may have uses, but it generally won't be as potentially effective, at least in the short term, as other treatments, just because the cancer cells aren't growing as quickly as in, say, a normal colorectal cancer or a lung cancer, if that makes sense. But there is evidence for different chemotherapy types, and that will be recommended, again, as I say, depending on your symptoms, your overall health, your other, and a discussion between ourselves and the patient, because chemotherapy will be generally used in what we would say is in a more advanced cancer, so trying to control symptoms. So sometimes it can make you less well than the cancer itself is doing. So it's about a balance.
There's another question in the Q&A box just saying, can we have more info on other treatment options? We are going to talk about other treatment options in other presentations as well. So we have interventional radiology coming up, and surgery, and also PRRT with some other presenters. So perhaps we can talk about those then. So Helen's just mentioned hormones and SSA.
Yeah, so hormonal treatments like lanreotide, which many of you may be on, are about, again, trying to control some of the symptoms that you're experiencing, and also it can work in controlling the cancer as well. So that's one of the options we have available to us. Again, dependent on the imaging and what's recommended at our multidisciplinary team meetings. Excellent.
Anyone got any other questions? Okay, we are running a little bit behind, so we'll move on to Tom Armstrong. So I'm going to bring him into the room. Thanks so much, Salma. That was great overview. So let me just bring Tom into the room. Mm-hmm. Okay, so Tom should pop up any second.
Hello.
Hi. Thanks
Hi.
for joining us. So you should have the option to share your screen.
Yep, I have.
Great. I'll let you introduce yourself, Tom. Most people know you already, I think.
Thank you, Jo. Now, can you see my screen?
Yeah, perfect.
Good. Okay. It'll look like I'm looking slightly differently because I've got two screens here, but I am concentrating, I promise. So I'm Tom Armstrong. I'm one of the surgeons at General Hospital, and I lead the Wessex NET group. Oh, so has that slide moved on?
It has.
Great. Okay. So what is the Wessex NET group? I just, for those who are new to this group, the Wessex NET group is a collection of clinicians who have joined together really to form a group that serves patients across the South Coast. And this really has been, Planets has been very central in the partnership of making all this happen, really. And so it really is a partnership. And let me just move on, sorry. So the way that the network is set up is that it's based around an MDT meeting in Southampton every week, and joint clinics that we run together as clinicians and nurses in Bournemouth and Southampton and Portsmouth. And you can see that patients feed in from all over the region in our part of the world. Some of the patients who might come from the north of Hampshire might be looked after by the team in Basingstoke and the King's Partnership, which is another centre of excellence. So I'm going to talk about the principles of surgical oncology, and they're slightly different in neuroendocrine tumours. So when we're talking about the majority of cancers that we deal with, like bowel cancer, for example, or breast cancer, the aim of the treatment is to remove the tumour with curative intent. And when we're doing that, what we mean is that we're treating all the disease that we can see on the scans. But patients often require chemotherapy as well, and that's to treat the invisible disease that we can't see on scan, so any cells that might be invisible, and we call this micrometastatic disease. But with neuroendocrine tumours, a different surgical mindset is required. So the aims of surgery in NETs is to cure disease if possible, but there are many cases where we can help set the clock back on the disease and reduce the burden of disease and help to improve symptoms for as long as possible, particularly those patients who are suffering with syndromes like flushing, people with bowel symptoms, and we also hope by intervening to slow down the progression or the development of things like carcinoid heart disease. But decision making in this setting is not straightforward, and the surgery is often challenging. When we're managing neuroendocrine tumours, there are certain principles that we have to abide by, and so a treatment for one patient might not be suitable for another patient. And one of the key things we rely on is assessing the Ki-67 or proliferation index of the tumour fairly early on when we're staging patients, and depending on this, it will inform what sort of treatment we're going to recommend. And not all patients who have neuroendocrine tumours are suitable for surgical treatment, or will it be of benefit to them. So when we're thinking about this, it's not just about the tumour, it's about where the tumour is, its size, the grade we've mentioned, and the stage, and Salma has touched on this in her previous presentation. Sometimes FDG PET is becoming useful in helping us decide, because that can give us some information about how these tumours are going to behave, and that's an exciting development in this field. We also have to tailor treatment to each patient, because some patients have other illnesses, and we have to take this into account and make sure that what we're going to do and recommend is going to benefit them, and also how the disease behaves. Sometimes it's good to watch and scan you for a period of 6 months or a year before deciding that surgery would be useful in treating you. One thing that's been very important about centralizing surgery and services for neuroendocrine tumours in general is that experience and an interest in the area helps improve the safety of surgery. So in our view, it's important to have a surgeon who understands and is interested in NETs looking after you. It's very important that when we're considering an operation, that the role of that surgery is defined by the whole multidisciplinary team. We have clear protocols around the time of surgery and enhanced recovery protocols that we use, which means that hopefully the stay in hospital is as short as possible and as safe as possible. And in Southampton, we've got an amazing multidisciplinary team who support us with all of the major surgical operations that we do. So when we're considering the role of surgery, we have this kind of algorithm And when we're sitting in the multidisciplinary team meetings, we know that we have many different treatment modalities available to us, of which surgery is one aspect of this. And it's important to consider it as part of a series of measures to help. So when we talk about treatment terminology, systemic treatment, as Salma mentioned in her just before my presentation started, systemic treatment is a treatment that affects the whole body and is carried throughout the body by the bloodstream. Local regional treatment is aimed at a specific area or body. So a classic example of this would be embolization of liver metastases, for example. When we're talking about surgery, sometimes we aim to do it with curative intent, but other times we're trying to reduce the disease burden, and we call that cytoreductive or occasionally debulking surgery. And multimodal treatment means that we're combining a series of treatments together. So there is, when we're talking about surgical procedures, I just run through these operations. The organs that we're operating on is the liver, the gallbladder and bile ducts, and this is the pancreas and liver side of things first, and the pancreas, which is divided into the head, neck and body and tail, and the spleen. And the liver is important in the digestive process because it produces bile, which is normally stored in the gallbladder. It's also, bile is important in cholesterol metabolism. And so quite a lot of bile is made every day. And the pancreas also makes digestive enzymes, as Tara was saying earlier on. The stomach, which is removed from this diagram, which sits up here, makes stomach acid. So all of the organs that we're operating on here produce digestive juices, and that's important because it makes the surgery complex. It has potential consequences on the way that your insides work and for complications after surgery. The other role of the pancreas is to produce hormones like insulin and glucagon, and when we remove part of the pancreas, that can have an effect and cause problems like diabetes. The spleen is an organ that is involved in managing platelets, which are little fragments of blood cells that help your blood clot, and also in your immune function, helping fight certain types of infection. So when we're planning surgery for pancreatic neuroendocrine tumors, we have a variety of different options. Sometimes we can just simply remove the tumor. That's very important. It's away from the main pancreatic duct, because if we go into that pancreatic duct, pancreatic juice can leak out, and because it's a digestive juice, it does similar thing to the surrounding tissues and can form nasty abscesses and long-term problems. So we use that on occasions, but it's not an operation that we do particularly often. If tumors are situated in the tail of the pancreas, we would generally do something called a distal pancreatectomy. And when we're dealing with neuroendocrine tumors, we would generally recommend that the spleen is removed at the same time, because it would then remove lymph nodes which are sat around the tumor, which help us stage and plan further treatment and understand the behavior of the tumor. If tumors are in the head of the pancreas, because the bile duct and pancreatic duct are running through here, it makes it much more complicated, and we end up doing something called a Whipple's operation, which involves removing the head of the pancreas, the duodenum, the bile duct, and the gallbladder. And when we're left with the end of the bowel, end of the pancreas, and the bile duct, and we have to join those ends together again, and we do it like this. So at the end of the pancreas, we use the small intestine to join on, and the bile duct here to the bowel. And this is what it looks like when we're actually doing it. You can see the end of the pancreas here. These are the blood vessels, the portal vein and the artery that are going into the liver, which is this organ here. This is where the gallbladder was sat previously. And you can see that bowel has been brought up and sewn to the end of the pancreas here. You can't quite see where it's joined to the bile duct. And this is what a Whipple specimen looks like when it's been removed. Sometimes we choose not to operate on pancreatic neuroendocrine tumours, and generally speaking, if they're under 2 centimetres, we would recommend that they're just left in place, and we would then do scans on a regular basis to monitor whether they were changing or growing. And there are certain factors that encourage us to operate at an earlier stage if the tumour was higher grade, or we were able to more easily remove it with a distal pancreatectomy or an enucleation, for example, whereas a small tumour that may be harmless in the head of the pancreas has a much higher risk of problems afterwards should we operate. So we're studying patients at the moment in something called the ASPEN study, which is a collaborative study from centres all over the world. And in patients where we're recommending observation, we're collecting data where we're trying to understand more about who we should be recommending operation to more early when the tumours are smaller, and who we can safely observe. So that's, and you know, in the Wessex area, a lot of patients have agreed to be involved with this, which is fantastic for us and for future generations of patients. So I'm going to move on to mid-gut neuroendocrine tumours now, and by that I mean neuroendocrine tumours that primarily arise in the small bowel and colon. So particularly the small bowel. So generally, when we're managing these, we would advocate resection rather than bypass. And by bypass, I mean that the tumour is not actually removed, but when a tumour is blocking the bowel, that the tumour upstream and downstream, sorry, the bowel upstream and downstream of the bowel is joined together, effectively bypassing the blockage. We wouldn't favour that unless it's absolutely necessary. And we often recommend this operation even in the presence of disease that has spread to the liver and peritoneum. And when we're doing this, we try and remove all of the lymph glands in the mesentery. And I'll show you a picture of what I mean by that in a minute, because it's really those that are often the main problem. And it often improves symptoms overnight. Blockage of the bowel, the effect it has on the blood supply to the bowel, and the scarring and inflammation these tumours can cause. We can't, unfortunately, remove all tumours in this situation. When the way that the blood supply is to the intestine, there's a main artery called the superior mesenteric artery that comes here, and it gives off lots and lots of branches. And there are these arcades where all of the blood vessels join together. So when we can preserve enough of these branches that the bowel will still get an arterial blood supply, it is safe for us to remove glands up to about this point. But when they're higher or blocking the main vein that drains blood back, or all around the artery up here, it means surgical resection is not safe because the bowel ends up needing to be removed. This is what it looks like. This is a relatively early tumour. So the tumour is the primary in the bowel up here, and there is a defined group of lymph glands there, and we remove the part of the bowel and the lymph nodes. And we try and preserve as much of the bowel as we can. It's not always like that, and when the tumour and the nodes are more infiltrative and develop this scarring reaction we call the desmoplastic reaction, the bowel can be much more profoundly affected, and this makes surgery much more difficult. And on this picture on the right hand side here, the white areas here are the intravenous contrast in the blood vessels, and if the tumour, which is the lighter grey area here, is around the branches early on in the mesentery, it means that surgery is just not possible in some occasions. So I'm going to move on to surgical treatment for liver metastases now, and this is quite a complex decision-making process. This is the guidance that comes from the European Neuroendocrine Tumor Society, and it depends on whether the secondary deposits in the liver are large and solitary, or whether there are multiple tiny liver metastases, and there are a whole range in between. All of the treatments we use have benefit. If we can do an operation to remove all the tumours in the liver, then that gives the best long-term outlook. The role of transplant in patients is coming back into review at the moment. And then there are the treatments such as embolization and ablation that we can also use. And so we've got all of these modalities available to us, and we commonly use a combination of all of them. So this is what it looks like when we do the surgery. So these are the tumors, and we often remove many tumours from the liver. This is the normal liver afterwards, and you can see the areas the tumours have been removed from. And it often has a sustained benefit. I'm just going to show you a video. So this is a liver before. You can see the multiple little spots in the liver here, all the way through. And then the same liver 6 years later looks slightly different. The little black spots are where we've operated, not the tumours recurring, but you can see that all of those spots have gone and remained gone. And when we talk about setting the clock back, it's likely that further disease will develop in this liver in the years to come, but we've set the clock back on the disease. When we're planning liver surgery, we have to think very carefully about the anatomy. There are large blood vessels that run into the liver and large veins that drain the liver. And where tumours are within the liver dictates what we have to do. If the tumour is situated on the edge of the liver, it's very easy to remove a small part of the liver. Whereas if that same single tumour is next to the blood vessels that go into the right half of the liver here, it means that we have to remove the whole right side of the liver, even though there's only the one deposit. And similarly, if the single deposit was next to the big veins that drain the liver, we often then have to remove the whole left side of the liver. More commonly with neuroendocrine tumours, there are multiple deposits, and we end up, as the pictures I've shown you before, removing multiple deposits. So we often do liver surgery in conjunction with embolization of liver metastases, which is what Sachin's going to talk about later. There's no randomized data with this. There's a problem with all management of neuroendocrine disease is that there is a lack of research, and there's a whole range of reasons for that, principally because it's very, very difficult to do. And we know that embolization is good for the small little tumours where surgery is not so good. We often have to do multiple treatment episodes, but it definitely has a benefit, and we find it a very useful adjunct to surgery, and it's good for helping control syndromal symptoms like flushing. Now, when we're considering all treatment, we have to consider what effect that has on quality of life. And we've done a study which Judith Cave has led called the Quantum Study, which patients from the region have been involved in. And what that has shown that the quality of life after surgery, as you would expect, is reduced for a period of time. But by after 3 months, generally speaking, the quality of life returns to the baseline. And one of our junior doctors is going to present this data at an oral presentation at the UK INETS meeting in a couple of weeks' time. So this is really helpful to know that we are recommending the right thing. So just to conclude, surgery does have a central role in management. It's tailored to each patient through our multidisciplinary team. It's often just one part of treatment for patients who've got disease that's spread from the primary site. And we know that it is associated with a transient reduction in quality of life, but it is only transient. So that's my presentation. I'm happy now to take some questions.
Thanks, Tom. That was really interesting, especially the process of how you work out what treatment's going to be appropriate, etc. I think that's really useful. So I can't see any questions yet. Has anyone got anything they'd like to ask Tom? Is Layla back in the room?
I think it's important to say that when we are considering all the treatment options, that we do try and talk to you as patients in clinic to share that information with you, because there's often not a right or wrong answer. And the problem with research in neuroendocrine tumors generally is that it's such a varied group of tumors. Often patients live for many, many years and often have had multiple different treatments, which means studying the impact of one single treatment is very different. And so one of the reasons that being part of a centre of excellence is a good thing is because it allows a large network through Europe for research purposes to try and develop and understand how we can treat you better.
Any question? Oh, we've got a question. Hang on, let me have a look. So a patient has said, when you say surgery presents a too high risk, what do you mean in terms of ratios generally?
So when we're considering surgery, we have to consider the benefits of surgery potentially and the risks of surgery. And when we're talking about the benefits, we have to recommend surgery only when we think it's going to benefit you in terms of quality of life and the length and health of your life. We can do operations, but we have to make sure that they have an impact. So that's one aspect. The second aspect is the risk of doing the surgery. A Whipple's operation, for example, carries quite a high risk of complications and quite a high risk of actually not leaving hospital afterwards compared to many operations, whereas other operations carry a much lower risk. And so we have to make sure that the treatment is something safe, and there are other illnesses that people have that mean that it's just the risks of doing a Whipple's operation, for example, are just too high. And so it's quite a complex process that we go through. And you're going to hear, I think, from Leslie Hawkins a little bit about WESFIT, which is all part and parcel of trying to make sure patients are fit for surgery, because it's quite a big physical thing to go through sometimes.
There's one more question here as well. What role does robotic surgery have in supporting tumour resection?
I think that's interesting. I think that the role of robotic surgery has been established in certain fields. One of those would be, for example, in prostate surgery. It is still in development in all other fields, and I think that it's certainly very helpful for operating in some areas of the body, particularly the pelvis, because the pelvis is there's a bony structure all around the organs in the pelvis. That means there isn't space to use the traditional keyhole surgery instruments. So so there is definitely a benefit in there, but the benefit of robotic surgery remains unproven elsewhere. And I don't think it could be considered better at present than many of the techniques that we use. So it remains unproven. And certainly for neuroendocrine tumors, there's maybe for the distal pancreatic resections that we do with keyhole surgery, there may prove to be a benefit. There's some of the bowel operations we do really are technically extremely difficult, even as an open operation, and I doubt will ever be suitable for robotic resection.
Okay, we've got one more question for you, Tom. It says, with regards to the lack of research, is that something that frustrates you, and could more progress be made more quickly if the research programme for NETs was better? And how is that being addressed?
So, well, I think that this is being addressed through the ENET Centre of Excellence programme, and it's because it's a rare tumour type, and because it's so it is the tumours and the way people present are so varied compared to many other cancer types, and so I think that this is the beginning of a process, and I think there's been a huge movement in the last 10 years, you know, with the centralisation of services and the European Neuroendocrine Tumor Centre of Excellence network developing that will allow much more coordinated research. It's very difficult to establish research across different sites, and particularly in different countries. So that there are quite a lot of barriers in terms of the process and governance around research that make it difficult.
Thank you. I I think that's all the questions. So thanks very much, Tom. That's really
It's a
interesting.
pleasure.
And I'm going to bring in Zia to the room.
Thank you. Cheerio.
Thanks.
Bye.
Bye bye.
So requested Zia to be a panelist. It's not working at the moment.
Okay, Tom's just come off, so. There he is.
Zia has disappeared. Layla, have you heard anything from Zia?
I'm just texting now.
I'm just sending him another link because he's disappeared completely.
The wonders of modern technology. Gives people a chance to have a quick break.
Yeah, grab a cup of tea if you're listening. We will get him back. So I've emailed Zia another request to be a panelist, so he hopefully can come straight in as a panelist if he clicks on that.
Yeah, I've told him that you've sent that over. That's fine. The connection at the hospital is not very good, as I've experienced in the last week. Horrific. He's trying again.
Can you hear me, Joe?
Yes.
Right, finally. Right. So
Asking you to start your video now as well, so hopefully we'll be able to see you in a second as well.
okay.
Yes.
Can you guys see me?
We can.
Excellent.
All
There
right,
you are.
brilliant. Technology. Right.
Be able to share your screen as well, Zia.
Can you see the screen?
Not yet. That's it.
There it is.
Can you see it now?
It says Zia has started screen sharing, but there's nothing. So if you open your file now.
Can you hear me and see the screen?
So we can hear you. There you go.
There it is. Excellent.
Perfect. So I'll pass you over to Zia now for our talk on nuclear medicine and PRRT.
Right, and I hope that everybody can see this screen, which I'm sharing.
Yes. No comments otherwise. Thank you
so much. Right, I'm Zia Saad. I'm one of the consultants in nuclear medicine and molecular imaging and radionuclide therapeutics because it involves PRRT at Southampton. Before we embark on to the main nitty-gritty of neuroendocrine tumors, I think it is very important that we solve some kind of misconceptions which relate to our specialty, basically because of the name and the attitude which it carries. And this is the general perception of nuclear medicine. And it carries a lot of myths. And because of those myths, there is a lot of mystery and fear which goes around. What is nuclear medicine is basically a specialty that uses nuclear and radioactive materials for the purposes of diagnosis and also for the therapy. And let me reassure you, it is medicinal grade and it is not at all a military grade kind of nuclear activity that will be given to our patients. What is the essence of nuclear medicine and molecular imaging and therapy is we see day in, day out, there are cancers which are hidden. So that is where our specialty comes in with a whole cohort of different kinds of radio tracers which are utilized and which helps making the invisible disease, mainly cancers, to the visible eye. If we see something, then we can target it. And nuclear medicine helps it to localize the disease and map it out. Why is neuroendocrine tumor most challenging bit? As my previous colleagues have talked about, this is just a refresher because they are derived from embryonic neural crust cells and they are pretty much everywhere. And as Salma has alluded to the different kind of symptoms which are produced, these are just a recap. And our patient group and patient cohorts are well versed with it. But typically flushing, diarrhea, tummy cramps, wheezing, these are all known as carcinoid syndromes, and they are prevalent in neuroendocrine tumors. The important aspect of neuroendocrine tumor, which I need to highlight, this is not a particular organ-specific cancer. It can go anywhere because it is based on the neural crest cells. And you can see what kind of varied profile this carries with it. And another important thing on the right-hand side, you can see this is, even though it can affect certain organ, it doesn't become that particular cancer. So if it is in pancreas, it doesn't mean that it is a pancreatic cancer. It will still be a neuroendocrine tumor. So we have reviewed this in the previous talks, but this is the general diagnostic algorithm that comes along with patient symptoms, and then a visit to the doctor, then the investigations come along, then the biopsy or the tissue, which is very important and cardinal to make sure that what we are dealing with is really neuroendocrine tumor, and it confirms it. Then we have got surgicals, and then we have got a specific histology, which shows you that it is definitively a NET. Then comes imaging aspects to it. There are structural imaging, and then there are functional imaging. So the last bit is just a flavor for the audience, basically, that how, as my previous slide has shown you, that with the help of functional imaging, which is, you can see that we can pinpoint the lesion, which might not be that much visible on structural imaging. Now, because of its challenge and unique nature of the disease, we have to have a unique multidisciplinary team board meeting. And to every everything, I must emphasize this, our patient is at the center. And you can see how many specialists give in the input before embarking to the best management of the treatment. So the key points that we consider in an MDT depends on various aspects of the thing, and they all are disease specific, in this case, the neuroendocrine tumors. When we know that it is either well differentiated or poorly differentiated, which is given to us by our pathology colleagues through the histology, then we further subdivide the cases into what kind of G1 or the grading of the tumors from a very low index into a very high index. It has got implication because it allows us to select the best modality of imaging and what kind of structural or even functional studies that we can go about. Up till the grade 2 tumors, we consider it as a slow growing or indolent. When they are outside 20% mark, then they become aggressive tumors. And we have got, as you can see, multiple management options available for the neuroendocrine tumors. As Tom has mentioned, the surgery is the hallmark in capturing the size or the bulk of the tumors, and even for the curative purposes. But when it goes systemic, then we have got the choices of somatostatin analogs, radionuclide therapy, or even chemotherapy. And there are other bits of chemotherapy or medical oncology which can be given. And in addition, we have got organ-directed treatment like SIRT, which Sachin is going to. Can you guys hear me? Sorry. Which Sachin is going to give a talk on.
Yes, we can hear well. It's all good.
Thanks, Joe. Right. What is the functional imaging and its role in the diagnostic side of it? So we need to select the patient, which we do in the NDT. Then it also detects and localizes the functionally active disease, as I've shown you the previous examples and will give you some more. It also helps in monitoring the response of the treatment throughout the course of the treatment. And if there are any relapse or progression down the line in the disease, then we can also monitor it through the functional imaging. What are the main kind of ammunition or different kind of radiopharmaceuticals that we have got in hand, which includes in the functional imaging? There are three main subcategories, and that is the reason why there are different kind of nuclear scans. Some are the nuclear medicine group, and some are the PET-CT, as you might be knowing, and some are the SPECT-CT, you might be knowing, and some are just plain scintigraphies that you might be knowing. So the hallmark, I've put it at the top. At this current times, it is the receptor affinity imaging analog, which are based on the indium, technetium, and gallium. And similarly, you might be familiar with terminologies like an octrio scan, which is indium-based, tetrotroid scan, which is technetium-based, and gallium-68 PET-CT scans, which is a specialized form of scan, but still it is the receptor. Before, about 20 years ago, or sometime 15 years ago, maybe, MIBG was our main workhorse in the field. And that is why MIBG scintigraphy was quite commonly used. And we used to do the MIBG scans for them because they are also very, very definitive in the neuroendocrine tumor. But we have got other PET tracers now as well, which is the F18 base and the DOPA based. And then finally, we also have got something called FDG PET-CT, which gives us or tells us about the perfusion index, i.e. How aggressive is the tumor and how much change it is causing in a short period of time. So these are a few examples of the different tracers and how they look in terms of imaging. And that is why there is a very valid reason we ask our patients or the NET patients to go for different kind of examinations or investigations in imaging, starting from the structural imaging side to the functional side. And you can see in the functional side, there are so many different traces, which I've just alluded from. So this is the example of an MIBG scan. This is the FDG PET scan, which tells you the aggression. This is a gallium PET CT scan, which tells you the extent of the disease. And you can see that the pattern of disease in the same patient is very, very different in different scans. And this is a tetratoid or the octreotide-based scintigraphy, but still it shows where the disease burden is. It helps us mapping out of the disease. At this current times, this is our two PET CT imagings, which are the gallium-based imaging and the FDG-based imaging, are currently used in association with octreotide and the tetratoid scintigraphy. And what all these things do, they form the mapping of the disease for the patient, that where is the disease of NET functionally active? And if it is active, then it forms the basis to provide the therapeutic option. What are the key things that of discussion? This is just a refresher, but it's a very, very important slide, that on what basis the patients are selected for which form of therapy. So the PRRT is a peptide receptor radiotherapy, and I would talk you through it. It's inoperable or metastasized NET. That means it has become systemic. The pathology is proven NET. That is why I showed you the slide that histology has got its important. There has to be a sufficient uptake on the different radio tracers. And currently, because we are using Octrio and gallium-68 scan, it maps out our disease. In terms of patient performance, the bloods are very important because it's a radioactive agent by the end of the day. And some effects are going to happen to the bone marrow, which produces cells like hemoglobin leukocytes and thrombocytes, which help in protecting us from infection, from anemia, and also from blood clots. These are the functions of the blood, so we keep close monitoring of it. Then we have got the structural imaging and the nuclear scans, and we want them, if we are embarking the patient for PRRT, to be as near the time rather than a year ago somebody have done this scan, because it will give us a better idea if there is a progression in the meantime. Again, there is going to be a talk later on the fitness of the patient. The more fit the patient, the better it is, and the outcomes have shown that. And one of the things that we consider as well, that the life expectancy at the time of making the decision to go ahead and do a PRRT should be around 3 months. Final decision, again, we all convene at the MDT and make our decisions once again and endorse it. Once we are all on the same page that the PRRT or the nuclear form of therapy is the best option available, or the next option available for the patient, then a referral, formal referral is made to me or Francis, one of my other colleagues. Now, what is PRRT? As I've told you, is the peptide receptor radiotherapy, but how does it work? This is quite a question that most of our patients do ask us, but in simple terms, it seeks and targets the tumor, and that is why it is termed as targeted molecular radiotherapy. And you can see that there are receptor cells, this count cancer cells, and this somatostatin analog based or receptor based therapy, it clicks onto it. Once it clicks onto it, then the radioactivity bit of it tries to shrink it, kill it, and produce the radioactive damage to it. And this is based on our Lutetium-177 dotatate PRRT. And it is simply, as I've just mentioned to you and shown you, this is a lock and key mechanism, and how it kills the cancer cells or control the cancer cells is on the basis of two effects, which is the bystander effect, where it gets locked inside the radioactivity, locks inside the cancer cell, and it gives the radiation and causes the cell death. The other one is the crossfire effect, which is just the huge burden of the radiation which is provided over. So the treatment, how the treatment is given at our department is PRRT is given by the intravenous route. There are usually 4 cycles in total. These side effects, there is a various kind of side effects profile to it. However, in a nutshell, there are pretty much things that needs to be looked at or focused at. It is not considered to be as a therapy which has got many side effects in combination to or compared with chemotherapy. However, we need to be having a close eye on the renal functions, because this is how the radioactivity comes out of your body once it has done the job. Then we have to have a close monitoring about the bloods and the different types. And then you can see the third line, which is the type of side effects which are there. The whole or the complete list of therapy, there are brochures and there are booklets. For the sake of this talk, it is going to be a very, very lengthy discussion. But these are the key things that the kidney functions we try to monitor and maintain, and the blood counts, and also the patient performance of our cohort. Essential conditions before embarking on the PRRT is also that most of our patients are already using the somatostatin analog, which are the lanreotide or the short-acting octreotide. We need to see the timing of it. It is a very, very important thing, because if the tumor cells are already occupied with a cold somatostatin, then the radiotherapeutic aspect of it would not work to the full extent. And that is why we usually keep 2 weeks distance between the cold analog and giving the PRRT. So where did this PRRT all arise? Although the PRRT has been here for about since 1989 or 1990s, it is actually the NET trial which has formalized it into the public and the NHS and the licensing and the funding, in which they came out and showed these results. The PFS stands for progress-free survival rate, and you can see the distance and the difference between when the medication is given versus the group where medication was not given. So in a sense, the hazard ratio is 0.21, which is an excellent, which is hardly seen in chemotherapy, has been shown. And that is why in the last 5 years or so, I must say, in the UK, it has picked up. Patient pathway, I should briefly tell you about it before embarking to the lutetium dotatate. We usually see our patient in the clinic before actually giving the lutetium dotatate PRRT therapy. And it is basically to have a meet of the team of the nuclear medicine and how it is given. All the questions that the patient have, or unanswered questions, I must say, or the myths they still carry, they are all tried to be resolved in that meeting. Then we move on to the lutetium therapy. We have moved a long way in the last 2 or 3 years. We used to admit our patients for an overnight stay. We still do, but in a very, very low percentage of patients. Now we have moved down to the day case in total. This is a brief overview in the cartoonist fashion that we have created, that the patient comes in, meets us, and then we discuss all the things. And once we are agreed, then the timing of the therapy and the consenting is all decided. Now it is NHS approved, but only for the neuroendocrines of the gastrointestinal tract and the pancreas. That is what we write the letter to for the funding to the NHS at this current times of moment, that it is approved for GEP-NETs, which is gastrointestinal enteropancreatic tumors. It is not approved for other site of NETs at this moment in time. Once we are all there, we get the consent forms and the treatment is given. And we keep them in the follow-up with us for the whole 4 cycles of the treatment. How the actual delivery is performed, you can see that we have got a whole setup in terms of radiation protection. It is, by the end of the day, a radioactive treatment, and we have to take care and precautions, not only for the patient, but also us as the administrators. And also nuclear physics is also involved to create a radiation protection, tailored, individualized shade to take home, and how, because they will be in the community, so how the protective sides of it can be managed. Usually it doesn't prolong more than 1 week of precautions. This is just one of the examples in which we had a patient who was at this stage when we selected, and over the 4 treatment course cycles, you can see the effect of the PRRT treatment and how it has stabilized and controlled the disease. And at few sites, you can see the extensive burden of the disease has also melted down. These are a few feedbacks in the last 3 years that we have collected, and we have done nearly 600 to 700 administrations in the last 3 years or so. This is what our colleagues have also furnished us with. And I must let you all go in conclusion that it is time to understand more so that we may fear less. This is by Marie Curie, one of the founders of the radionuclides. Thank you very much, but I'm here to take any questions from you. Joe, over to you.
Thank you very much. I think we did have a couple of questions in advance, but I feel like you've addressed those in your presentation there. But if anyone has any more questions, then please pop them in the Q&A box for us.
Joe, I cannot see the Q&A box live, so if you can read them out, I'm happy to answer those.
No problem. There's none so far. I think you would spot them if someone popped one in. Okay, so I don't think there's any questions coming in, so I think you covered everything there. So we have Sachin next, but we're going to have a little break. So I'm going to bring Sachin into the room shortly, but if everyone wants to just take 5 minutes maybe to grab a coffee, loo break, and then we'll come back in at about 20:22, if that's okay. Try and make up a little bit of time. If anyone has any questions later on that they think, so first of all, you'll be able to watch these presentations again. I expect everyone that's spoken today will send their presentations to me to share. So you can rewatch and then you can come back to with questions. So don't panic if you think of something at the end. We also have a little Q&A time at the end as well. So I'll let Zia go, and everyone go and get yourself a quick break. Thanks very much.
Bye-bye.
Bye. Hi, Neil. Thanks for joining us.
Hi, Joe. Yeah, no, I need a little bit of a snooze beforehand, a bit of recovery time. I'm still a bit knackered, strangely enough, after my little brush with death.
Well, it's good to see you, and thank you for joining us. You can help us with the Q&A in a bit. That's what we need you for anyway.
Yeah, that's what I thought I'd join you for.
Perfect, thank you. So I think we're all good to go. We've had a couple of minutes. So Sachin, you're on whenever you're ready.
Yeah, can you hear me okay?
I can hear you, and we can see you, and we can see your screen. So all set.
Okay, great. Good morning, everyone. My name is Sachin Modi. I'm an interventional radiologist working here at Southampton as part of the NETS team. And I'm going to talk to you a bit about interventional radiology and our role in the treatment of NET patients. Who are we in interventional radiology? Well, we're like the Ghostbusters. It's kind of like who you're going to call, and we get called quite a lot for help with neuroendocrine patients. In our team, we have Dr. Bryant, who you may or may not have seen. We've got Dr. Steadman, who of course you all know, and myself, and as well as some other newcomers. And what is interventional radiology? So interventional radiology is minimally invasive image-guided surgery. And we have our fingers in a lot of pies. We're able to have an impact in various different health conditions in various different parts of the body, from stopping bleeding in patients with trauma to stopping aneurysms from bursting, delivering chemotherapy to liver tumors, a huge range of medical problems that we're involved in within the hospital. And from interventional radiology has derived this kind of new specialty called interventional oncology. And traditionally we think of cancer care with these three pillars of oncology, being medical oncology, which would be treatments like chemotherapy, surgical oncology, and radiation oncology. And now we've now coming into a fourth pillar of cancer care with this interventional oncology, which is mainly focused on liver-directed treatments. So you guys have probably seen this before, but the most common tumors are midgut nets, and these tend to be functional. We use the grading system of the nets to determine which patients are most suitable for different treatments. And we use this Ki67, which is an indicator of how quickly the cells proliferate. And that gives us an indication as to the grade of the tumor. So the higher the Ki67, the faster the cells are proliferating. And so neuroendocrine tumors from gastropancreatic origin, they can be responsible for metastatic disease, and they're often the most frequent metastatic site. And the metastases in the liver can be the most dominant part of the disease in terms of tumor burden and in terms of symptoms related to the metastases. And the ENETS guidelines recommend that we treat grade 1, 2 tumors as candidates for liver-directed treatments. And we don't tend to treat grade 3 tumors, carcinomas, as these patients tend to progress quite rapidly and have disease outside of the liver as well. So those don't benefit from liver-directed treatments. So what are the goals for us? Well, in an ideal world, we want to get rid of tumors in the liver, kill them off, get them to shrink down. So that's one of the aims, is to reduce the tumor burden. The tumor burden in the liver is what affects survival. What we want to do is prevent these tumors getting too big so that they don't affect the liver function. So that's important. We want to potentially make more people available for surgery. So if we can treat a certain part of the liver, that means that Mr. Armstrong or Mr. Tafa can remove another part of the liver that can help the patient. So that's another thing we can do. And the other thing we can do is to control symptoms related to the metastases, such as the hormonal symptoms, when the other systemic somatostatin analogs fail. So the mainstay of our treatments that are available are transarterial therapies, and these are we can divide these into these three. So we've got TACE, which is where we block arteries with beads and chemotherapy. We've got transarterial embolization or bland embolization, where we block arteries with just particles alone. And we've got selective internal radiation therapy, which is SIRT treatment. And that's where we deliver particles with radiation on them to affect the tumors in the liver. So I'm going to talk to you about some of these. The rationale for this treatment in the liver is because the liver has two blood supplies. 80% of the liver is supplied by the portal vein, which takes all the blood from the gut into the liver and provides it with all the goodies and nutrients, and that tends to supply the normal liver. Tumors in the liver tend to take their blood supply from the hepatic artery, which usually contributes 20% of the inflow. And this differential supply between tumors taking their blood supply from the artery and the normal liver taking its blood supply from the portal vein enables us to deliver these liver-directed treatments. And neuroendocrine tumors are especially good candidates for these liver-directed therapies because they are very arterialized. They take a lot of their supply from the artery compared to disease spread from other cancers, such as colorectal cancer or breast cancer. So for us, they're a very good target. And this is just a diagram just to show what I just explained, that it's the 80-20 split in the blood supply. And this here is a patient with the neuroendocrine metastasis on the left-hand side. This is the liver here, and you can see this bright tumor here in the liver, at the top of the liver. This is a scan that is performed with contrast, so you can see the white. This is the contrast in the aorta, which is the main blood vessel in the body. And you can see that this tumor is lighting up with white bits similar to the contrast in the aorta. So this is what we call an arterialized lesion. And on the right here, we have a patient with similar contrast in the aorta, but you can see these lesions, these rounded areas in the liver are not lighting up like on the left side. This is a patient with colorectal metastases. So this is just to show you the difference between the arterialization in neuroendocrine metastases in the liver and other cancer types. And typically this is a picture from an angiography, which is when we take pictures in the blood vessels. You may be able to make out a catheter here, which is in the liver arteries. And as I do the injection of dye, which is black, as it comes out, you start to see these rounded areas here within the liver. And these are the arterialized tumors that we can see taking the blood supply very rapidly. And the hope is that if we can get into the arteries supplying these areas, we can block off the blood supply to these tumors, make them unhappy, help them to die, and then shrink down in size. So this is another example here, an injection. You can see this big tumor here at the bottom's enhancing very, very rapidly. And we don't see that in the rest of the normal liver. We're just seeing it here in this tumor. So that's a difference. So what type of patients are suitable for embolization? We want patients that have generally good liver function because putting these beads in the arteries, blocking off certain amounts of the liver can make the liver unhappy. So we want patients to have a good liver function to start with. We want them to be reasonably fit and well, so they tolerate the procedure well. We want to treat patients who've got a portal vein, which is the other blood supply, intact. We don't want to treat patients who've got a blocked portal vein, because if we have a blocked portal vein and then we block the artery as well, we may risk them going to liver failure. So we're cautious of patients with PVT, which is portal vein thrombosis. The relative contraindications are patients who've got arteries which are difficult to get into because they're very crusty or they've got little tears in them. We also don't want to treat patients who've got huge volumes of disease, because then it can be quite difficult to get that under control and can affect the patient quite adversely. Some patients after surgery can also develop liver metastases where they have connections between their bile duct and their liver. So patients who've had Whipple's operations, and we're careful with those patients because they've got an increased risk of relatively increased risk of infections. So this is a patient who's got greater than 50% disease in the liver. So this patient is difficult to treat. We do treat some patients, and it's a decision that's made at our neuroendocrine MDT. We can target certain parts, small parts of the liver at a time to try and control this, but generally we're cautious when the disease is over 50%. So as I mentioned, we have an MDT discussion at UHS where we've got a range of specialists who are specialized in looking after patients with neuroendocrine tumors. Once the decision is made for a embolization, patients are referred to us here Generally, we're seeing patients now in clinic to explain the procedure to them beforehand, either on telephone or in person. And we have a couple of IR specialist nurses who help us with the process, help patients through the process. Some patients will come in the day before if they're symptomatic for octreotide infusion to prevent over secretion of hormones. So this is sort of a guideline we use. We grade patients into different categories depending on whether they've got functioning tumors or non-functioning tumors and whether we're doing a major operation or a minor operation. So depending on that, this gives us the protocol of what we give our patients when they come in of octreotide. So that's what we use. And generally, the procedure takes about 45 minutes to an hour, depending on how easy it is to get into the liver arteries and how easy it is to block these arteries. We tend to get access in the right groin. After the procedure finishes, we take the tube out, press there for 10 minutes, or use a little plug to close that hole. Patients usually stay a couple of days after the procedure to continue the octreotide infusion and recover. We generally call the patient, well, our specialist nurses call the patients day 1 post-discharge and day 3 and then 7 just to check they're okay. Commonly, patients will feel a bit tired after having an embolization, maybe a bit sick, off their food. This is something we call post-embolization syndrome. And we usually send patients home with painkillers and anti-sickness medication. We then follow up patients with imaging, either CT or MRI scans, and then we review the scans at our MDT and decide whether there's any need for retreatment. And so, you know, these patients with neuroendocrine metastases have a normal background liver, which is different to some other patients we treat who've got unhealthy livers to start with. So patients with cirrhosis and primary liver cancers don't have normal background livers. So we have to be a bit careful in patients with normal background livers. We don't want to cause harm to the normal liver. So we want to try and just select the arteries that are supplying the tumors if we can, rather than treat the whole side of the liver. And usually we do stage treatment. So if you've got disease on both sides of the liver, we'll treat the right side first, give you a little break, and then treat the left side. And similarly, if you've got different parts of the liver that are affected, so if you've got disease at the top of one side of the liver, we'll treat that first before coming back to treat the other side. And what we want to do is slow the flow of blood to the tumor. So if you imagine like the branches of a tree, we deliver the particles in, so the particles travel further into little branches until they sort of back up like little grains of sand until the main artery is blocked or very slow going forward. We've got lots of kit. We've got these different shaped catheters and microcatheters which allow us to access the liver arteries. And you know, the kit has really developed over the last few years. So there is not really an artery we can't get into now. There's lots and lots of different things we have and tools we have to do this. So this is an example of a patient who had two, this one I showed you before actually, so the tumor here at the top of the liver and one here at the bottom of the liver. They came for an embolization procedure, and this was the first injection in the hepatic artery, and you can make out that's the lesion at the top there, and there's also a lesion here at the bottom. I'll just play through that again. So what we did was we tend to go further in with a smaller microcatheter to select. You can see this is the microcatheter here. It's done all these loops inside the blood vessels so that we try and select the vessels that are supplying the tumor only. And then we deliver these little particles which block the arteries. And this is a follow-up at 6 weeks. So you can see now this tumor at the top of the liver is much smaller. It's no longer got any brightness on it, so it's no longer actively living. So we've killed this tumor and it's shrunk down in size. And similar here with the one at the bottom of the liver. So this is a very good response. So, these are other examples of patients where this is another example of a patient where had lots of tumors in the left side of the liver. So here's the main hepatic artery, and it splits into the right here, and this is the left. But this time we put our catheter in the left hepatic artery, and we delivered the beads in there. And you can see after a couple of weeks, all these little black areas here are the tumors that are now dead in the left side of the liver. So we've controlled the disease in that side of the liver. This is something that is called a rotational CT. We use this tool when we're in the operating theatres. We can inject dye and the machine can spin around you, and it can give us a better, more detailed picture and look at the liver to see which tumours are being supplied by which blood vessels. So you can see the tumours here are lighting up, so we can really accurately find the vessels we need to find to target these tumours. So this is an example of a patient who had a large tumour here. We blocked it off, the blood vessel supplying it, and then the patient went over to have it resected, to have it operated on. And doing this sort of thing beforehand makes the operation a lot bit safer, you know, less likely to bleed. So that's something that we get involved as well. Now, with the embolization procedures, the TACE, so that's the beads with the chemotherapy, or the beads alone, we tend to use particles which are about 250 microns, so with a range of about 100 to 300. And this is enough to block the vessel which is going into the tumor. They're not small enough to go very far right into the tumor, but the aim is to block the vessels around this point here. And this is slightly different to other treatments, radioembolization, which we're going to talk about later, where we want to deliver very, very small particles in and around the tumor so the radiation can have an effect. Whereas here, we're just delivering the beads into this part of the blood vessel. What's the evidence for it? These are some studies that show that there is a case for using TACE in patients with neuroendocrine hepatic metastases. These two lines here show the survival being better in patients being used with surgery and TACE, and similar here, patients with embolization did better than those with medical treatment. So there is evidence for it, and that's why we do it. And we do a lot here in Southampton compared to some other centres. Some of the potential complications that can occur following a TACE or an embolization procedure. I mentioned that patients with neuroendocrine tumours have normal background livers. We want to be careful we don't damage the normal liver. So this is a patient, unfortunately, has got some damage to the normal liver with dilation of the bile duct. So they've suffered some biliary injuries, and we have had some patients with that. So we're very cautious with that. Also, sometimes when we embolize a tumour like this, it was dead, but it also became infected. This patient then had to have a drain put in this tumour to drain that out, and subsequently it was well treated and the patient did okay, but this is another potential complication that can occur, is infection. So now come on to radioembolization treatment, which is also called SIRT treatment. Unfortunately, this treatment is not available on the NHS currently, although a lot of work is being done behind the scenes to try and get some funding. Recently, it got approved for funding for hepatocellular carcinoma. So things are changing in the UK, and we hope that within the next year or so, we may get some positive news, because this is a very good treatment for neuroendocrine tumours as well. So this treatment is different to the TACE treatment. In this treatment, we're delivering very, very small beads, much smaller than the ones we use for the TACE. And they have a radioactive substance on them called yttrium, Y90, which is a beta emitter, and it emits radiation between 1 to 2 millimeters. And the aim is to put loads and loads of these particles, millions of these particles in and around the tumor, so they can has a radiation effect from the inside out. This is different to other types of radiation, which you may have heard of, which is generally from the outside in. This is a two-stage procedure. So the first stage is a workup where it's done as a day case, where we take pictures of the liver blood vessels. We want to determine which blood vessels are supplying the tumours, and we want to deliver a test dose of radiation, which is this technetium labelled MAA, into the liver. I want to see that the liver tumours are taking up the radiation rather than the normal liver. So we do a test dose, and this helps us to calculate the dose that we need to order for patients. So in patients like this, often we have to block some blood vessels which can be supplying other organs. So in this case, this is the gastroduodenal artery, which supplies the duodenum. So we didn't want to put any radiation in there, so we put some coils in there to protect it. This is a patient who's got a falciform artery, which supplies the anterior abdominal wall. Again, we put a coil in it there. We want to prevent things like this. So not from us, but this is from another centre, but radiation damage to the skin on the anterior abdominal wall. So we do those things to carefully protect those blood vessels. And then we do the job of trying to hit the tumor. So this is the liver tumor here, and we're trying to hit the liver tumor. So we have to be accurate. You know, we don't want to whack the normal liver. We want to hit the liver tumor. So we don't want to do what this kid's doing. And so we use very clever software to calculate the liver volumes and to determine the radiation dose that we need to appropriately treat those tumors. Once we've worked everything out, we order the dose, which usually comes from Germany, and we treat 2 weeks later. And that involves a hospital overnight stay, 1 night in hospital, in a side room. The radiation dose is isolated to the liver, so that after you discharge, there's no risk of irradiating your family and things like that. There's a scan the next day to make sure the tumor, the radiation went where we anticipated it to go. And similar to the TASE procedures, we either press on the groin or close the groin, and you get this is what we want to see. We want to see radiation within the tumors, you know, and not in the liver. So this is radiation in the tumor, but not in the normal liver. That's what we want to see. Typically similar side effects to TASE, although better tolerated. Similar things: nausea, pain, bit of loss of appetite. Very rare risks with this procedure of non-target embolization, so radiation going somewhere we don't anticipate it. Doesn't usually happen in our hands. And the other thing to be worried about is radiation damage to the normal liver, but that's where the careful dosimetry comes in to minimize the risks of that happening. Okay. Generally, we follow up patients a bit longer after radioembolization. It can take some more time for it to work and for the effects to show on scans. So usually we scan at about 2 to 3 months. And there's evidence for that as well. So in other centers in Europe and America, they do use radioembolization for treatment of neuroendocrine metastases, and patients did very well. As you can see, the majority of patients had a partial response or stable disease, and 97% of patients had tumors that didn't have a blood supply at 3 months. So that was good, and also improving the symptoms of patients. What are the other things we can do? As I said to you before, the kit that we have now has improved significantly. We are able to target smaller and smaller blood vessels that before we weren't able to do. This is an unfortunate patient who had an insulinoma, which is a neuroendocrine tumor in the pancreas. You can see this bright area here that's enhancing, and was supplying excess insulin. So the patient was kept on being hyperglycemic, having low sugars, and wasn't fit for surgery. So we managed to, you can see how tricky this was in the blood vessels, and then this small microcatheter, which is right into the blood vessel, supplying this insulinoma, which is here, and we blocked that off with small particles. This is another patient, had another insulinoma here, and again, we went into the blood vessel and blocked this off. So we were one of the first centers to do this type of embolization. We published our findings on this. So there's lots and lots of things that we can do. And coming on to the holy grail really for us here at Southampton, my colleague Dr. Steadman has been involved in this treatment from its conception in the UK, which is called chemosaturation therapy, which we've been mainly using for patients with ocular melanoma metastases to date, and have had very good results and safety outcomes. This is a different type of liver-directed treatment where we deliver chemotherapy into the liver via the arteries like the other treatments, no beads, just the chemotherapy alone. But at the same time, we capture the blood coming out of the liver through the hepatic veins with these 2 balloons. That blood with chemotherapy comes out of the body, gets cleaned via this filtration system, and then returned back to the patient via a tube and then X. So essentially, we're bathing the liver in chemotherapy without it affecting the rest of the body. And we feel that this would be a very good treatment for patients with neuroendocrine tumors. So this is an example. We're delivering the dose into the artery, and at the same time, we're capturing the blood which is coming out of the hepatic veins. So this is in between the 2 balloons. And this is the blood coming out of the filtration system.
Let's go on.
It's blood coming out through that balloon catheter. It's going through this pump.
So it looks to be drawing okay.
Through the filters.
Back up through the bubble trap. And then returning the blood to the patient.
So that's going back to the patient there. So, and this is some of the responses we've seen in patients with melanoma metastases. So small lesions that have disappeared on subsequent scans, and big lesions that have got smaller and lost their blood supply. So we're very optimistic about this, and we've had some preliminary discussions recently with the company that makes this product, Delcath, and there's hope that we will be able to have a trial soon here at Southampton to allow treatment of neuroendocrine patients. There haven't been many neuroendocrine patients treated with this around the world, and we hope to be one of the first centres worldwide to be able to offer this to some patients. So fingers crossed, we'll have some good news for you soon. This is some of our team, IR team. Thanks to Planets for our lovely scrub hats. This is some of our nurses at the recent Planets ball. So you may have seen some of them there. But thanks for the invitation, Joe, for the talk today.
Thanks for presenting. It's great. Thank you very much. There is a question. I don't know whether you can see it or not. Someone has asked, what happens to the tumours that die off in the liver?
Well, generally they shrink down where they are. The tumours, once they start dying, they tend to shrink down and involute. So what happens, the centre of the tumour tends to liquefy, and then the tumour just tends to shrink down and stays there where it is dead. It doesn't necessarily disappear, although it does depend on the size of the lesion. So as you saw in those cases that I showed, the tumours generally shrink down in size and lose their blood supply.
Any other questions for Sachin? None have popped up. I don't think there's any on the chat either. But again, as I said before, if you think of anything later, or you watch the presentation again, maybe to take a little bit more in and think of a question, then just let us know and we can pass on. So I think that's everything. Thank you very much. We'll move on to the next one, which is Jocelyn Walters. So I'm just going to bring Jocelyn onto the panel. So Jocelyn is going to talk to us today about, let me just check she's in. Yes, it's worked. Jocelyn's going to talk to us today about clinical research and trials. So we asked her to join us just to explain the process a little bit better, so that we can all understand how this might work for us in the future and how we can keep an eye on things. And so welcome, Jocelyn. Thanks so much for joining us.
Thanks ever so much. Can you hear me okay?
I can hear you. And you
Brilliant. Are you okay to control my slides, Joe?
I am, yeah. Let me just open.
Brilliant. Thanks ever so much. Thank you. So thank you very much for inviting me to talk to you today. So my name's Jocelyn Walters, and I work for the Clinical Research Network here in Wessex as a Cancer Research Delivery Manager. So my role is to support and promote the cancer clinical trial portfolio across the region. And I'm also a programme manager within Southampton Clinical Trials Unit, where I help develop new early cancer diagnosis trials for delivery across the country. Next slide, please. So for the next 15 minutes or so, I'll just give an overview of cancer clinical trials. I'll explain what a trial is, how these are delivered, some of the pros and cons for a patient of taking part in a clinical trial, and where to find out more about what clinical trials are open in your particular region. And then finally, I'll just highlight some of the UK clinical trial successes and talk about some of the new exciting early cancer diagnosis studies that we're starting to deliver at the moment. So what is a clinical trial? Well, before a new cancer drug or treatment can be offered to patients on the NHS, it needs to be rigorously tested to find out if it's safe, whether it has any unwanted side effects, whether it works better than the current treatment, and ultimately whether it helps the patient feel better. Next slide, please. So we categorize clinical trials into phases, so phase 1, phase 2, and phase 3. And when a new cancer drug or treatment shows promise in the laboratory, then it will first go into a phase 1 clinical trial. And this will be the first time that the new drug or treatment will be given to a patient. So we want to know whether it's safe and whether it has any unwanted side effects. And phase 1 trials are only run in specialist units where patients can be very closely monitored. And because this is the first time that we're giving these treatments to patients, cancer patients who are eligible for these trials will be patients with quite advanced disease and who have exhausted standard treatments. And there's no expectation of any benefit to the patient for taking part in these trials. If the drug looks promising in phase 1 trial, then it will go on to a phase 2 trial. And the aim here really is to see whether it actually works. And again, small numbers of patients are involved with advanced disease. Now, a phase 3 trial is where we compare the new drug with the best standard treatment. And the expectation when a drug gets to phase 3 is that it's at least as good as the best standard treatment. So patients who are offered phase 3 trials are often much earlier, with much earlier stage disease and often newly diagnosed. And patients who take part in these trials will be assigned to either the new cancer drug or the standard treatment by chance. And that's called randomization. And the reason we do that is to avoid any bias in selection of patients and make sure that when we're comparing the new treatment with the standard treatment, we're doing it fairly. And if a drug is shown to be more effective than standard treatment in phase 3 trials, then it will go through to an organisation called NICE, and they will review whether this treatment can be offered on the NHS. Next slide, please. So cancer clinical trials are embedded in the NHS. Every single hospital in the UK will have a portfolio of cancer clinical trials to offer its patients. And every healthcare professional in the NHS will either be aware of or involved in delivering cancer clinical trials. And I've just listed a few of these here. Next slide, please. So alongside the treating clinician or oncologist, the key NHS staff involved in delivering cancer clinical trials are the research nurses, the research radiographers, and the clinical trials assistants. And these staff will be involved in, will be with the patient at the very beginning, when the trial is first discussed with them. They will take the patient through the patient information sheet, which I'm sure you can imagine for cancer trials can be really quite complex. And they will make sure that the patient understands exactly what the trial will involve and what any potential risks and benefits are. In the specialised phase 1 trials units, the research nurses will actually be the ones giving the novel treatment to the patients. These staff will also monitor side effects while the patient's on the study. They'll arrange all of the trial-related tests and procedures and collect all of the data which will be sent off for analysis. They're also the first point of contact for trial patients regarding any queries, whether they're trial-related or not. And in Southampton, we've got a very large team of, I think it's probably over 70 research nurses, radiographers and clinical trial assistants involved in just delivering the cancer clinical trials. Next slide, please. So cancer clinical trials aren't for every patient, and there are pros and cons of taking part in these. So I just thought I'd highlight a few of these. On the plus side, excuse me, If a patient takes part in a clinical trial, they will possibly get access to a trial drug which is better than standard. They may possibly get access to a trial drug which has fewer side effects than standard treatment. In almost all clinical trials, we do a lot more tests and an awful lot more visits. And for a lot of patients, this can be quite reassuring. There's the altruistic angle of improving treatments for cancer patients in the future. And then, as I said earlier, every trial patient will have a dedicated research nurse, radiographer, or clinical trial assistant who will be coordinating their care throughout the trial. On the downside, patients can't choose the treatment that they may get on a clinical trial. So as I said earlier, particularly with the phase 3 trial, allocation of treatment is randomized. So if a patient is hoping to get the new trial drug, which he or she may perceive to be better than standard, then there's no guarantee that that will happen. Sometimes the side effects associated with the trial treatment are worse than the standard treatment. And of course, for some patients, additional tests and visits, etc., are an inconvenience. And for the specialised phase 1 studies, as I said, these are only run in certain units across the UK. So this will, for some patients, will require travel out of area to take part in these studies. Next slide, please. So where can patients and the public go to find out more about what clinical trials are available in their area? Well, for patients with cancer, the first port of call will be their treating clinician or oncologist. Every oncologist will be involved in delivering cancer clinical trials in his or her hospital, so will be aware of appropriate trials that may be suitable for their patients. Excuse me. But there are also some really useful websites that are publicly accessible, where patients or the public can go to see what trials are currently available. And I've just listed a few of these here. So the first one is the NIHRB part of research website, and this website will showcase every single clinical trial that's open currently in the UK. So it's not just cancer, it's any disease area. Cancer Research UK do their own website, and of course they're only going to highlight cancer clinical trials, but you can search by tumour site and geographical area as well. Next slide, please. Thanks. And of course there are a lot of tumour-specific cancer charities, and on their websites you can look purely at clinical trials available in particular tumour sites. So I looked at UK INET, which is your charity. Next slide, please. The other day, and I did a search to see what trials were available. And I found that there were 4 trials that are currently open to recruitment in the UK, and I could also see which sites these trials were available at. Next slide, please. And then finally, in Wessex, we've developed our own website, which is called Cancerline. And what we wanted to do here was to showcase cancer clinical trials that are available in our region. So on this site, you can search and see what trials are available at each of the acute hospital trusts in Wessex. You can find out, you can search by disease and tumour site, and you can also search by phase as well. And all of these websites will have contact email addresses that you can use if you want to find out more information. And certainly I get emails on the Cancerline website, not a huge number, but they do come through, and we are able to respond and hopefully point members of the public or patient in the right direction. Next slide, please. So just coming towards the end of my talk now, and I just wanted to highlight the success of cancer clinical trials in the UK over the last 2 decades. And back in 2000, the UK really compared quite poorly to other European countries and to the US in particular in terms of our recruitment to cancer clinical trials. So for every 1,000 newly diagnosed patients with cancer, only 38 took part in a high quality clinical study in 2000. So that's less than 4%. And then in 2019, that had increased to 300 patients, or 30%, or 1 in 3, which I think is an amazing statistic, and really the result of an awful lot of sustained investment in clinical trials over the last 2 decades. And certainly now, UK is ranked amongst the most research active countries in the world. And next slide, please. And then lastly, I just wanted to highlight some really quite exciting new early detection trials that we're involved in our region. And these studies are aiming to detect cancers at an earlier stage where they're more treatable. And the NHS has recently published its ambition to increase the number of cancers diagnosed at stage 1 and 2 to 75% by 2028. Currently, only around half of cancer diagnoses are made at these earlier stages. So the GRAIL Simplify study, you may have come across this, it was on the national news, I think about a couple of months ago. And that trial is testing a really exciting new technology which can detect tiny fragments of cancer, of tumour DNA in the bloodstream of patients before they may even be exhibiting symptoms. And there are a number of trials testing this technology in the US and the UK. And in Wessex, we're taking part in one of these, which is actually going to close on Tuesday, having recruited 2 target, which is fantastic. So we're hoping that sometime next year we'll get some preliminary data from these studies. And then the other early cancer detection study I just wanted to highlight was the IDX lung cancer screening study. And that's a study which is partnering with NHS England Lung Health Checks programme. And the Lung Health Checks programme invites participants who are at higher risk of developing lung cancer because they're current or previous smokers. And these participants are invited to come for a CT, a low-dose CT scan. And on the picture, the bus on the left is the CT scanner, and the small van on the right is our research van, and that's where we're offering participants the IDX study. So when participants come for their low-dose CT scan, we approach them and ask whether they'd be interested in taking part in the study. And the study involves taking a blood test and also a sample of cells from the patient's nose. So these are epithelial cells. And what we're hoping to do with this study is to identify some markers in the blood and in the nasal epithelial cells, which hopefully may eventually be able to be combined with a low-dose CT scan, and which will improve and increase the detection of early lung cancers. And that study is open currently in Southampton and Leeds, and we're hoping to open in Manchester early in the new year. So apart from these, there's some other really exciting and innovative early detection technology, some of them looking to pick up chemicals in patient urine, some of them looking to pick up and measure volatile organic compounds in patients' breath to try and identify cancers at an early stage. And I think they offer enormous hope that over the next few years, that we will be able to detect more cancers at an earlier stage where we know they're more treatable and indeed more curable as well. So next slide, please. And thank you very much.
Thank you, Jocelyn. That's really interesting. So question from me as a patient, do you think patients should be always sort of proactive about looking for trials, or is it something that you should sort of, would it be mentioned to you by your clinicians?
So yes, I think we would. I'm sure, I don't know whether Judith, or there are certainly, I know oncologists probably who are involved in planets, but I'm sure, and I know oncologists would welcome any patient coming into clinic and saying, first of all, you know, can you tell me what's available in clinical trials for me? They would absolutely love that. And that's why we're trying to publicize these databases and to encourage, not only, the public, but patients to go and have a look and see what's available. So yes, I think it would be fantastic if we were more, if we could make ensure patients are more aware of what's going on out there. But certainly, as I said, clinical trials is so embedded in the NHS that our healthcare professionals are always looking to see what trials are available, for as many of our patients as possible.
Thank you. I think that's been really useful today to talk about that, because as a patient, I suppose I wouldn't necessarily think about being that proactive. So hopefully that's given everyone a bit of an overview of how it works. Has anyone got any questions for Jocelyn before we let her go? None so far. But again, as I've said earlier, if you think of any questions later, then you can send them over to us and we can get in contact with Jocelyn. Thank you so much for giving up your time. That's great.
Thank you.
Thank you. Okay, so I'm just going to bring Leslie into the room. So Leslie is from Westfit, and she's going to talk about the trial, Fit for Cancer trial they are doing. So let me just get the video going. She's there, she's just hiding behind the screen at the moment.
Bear with me. Can you see me now?
Anne, hi Leslie. Thanks for joining us. Sorry, we're a bit late.
That's fine. Thank you for the invite. I'm going to share my screen, so hopefully it will work. Can you see that?
It says yes. There we go. Perfect.
Got it. Brilliant. So I'm on two screens. So again, I might look like my posture is slightly different. So let's just make that. Okay. Can you see that? Okay.
Yeah. Perfect.
Okay. And you can hear me. Okay. So I'm Leslie. I'm from Southampton. I'm a senior trial coordinator for the WestFit and SafeFit trial. And I want to talk about why and how we moved from WestFit to SafeFit. So as you can see, I'm also part of the Fit for Surgery consortium that runs out of Southampton as well. So SafeFit is virtual clinics to deliver universal interventions to maintain and improve physical health and psychological well-being of people with cancer who are following social distancing guidelines. So from WestFit to SafeFit. So WestFit was our predecessor to SafeFit. So this was looking at, it's a randomized controlled trial of 4 groups of obviously randomized to any of these groups. So group 1 was hospital, which was standard care with some extra questionnaires and monitoring. So group 2 was exercise in a community gym. And group 3 was psychological support at a wellbeing centre. And group 4 was a combination of exercise and psychological support. So these were participants that were going straight to surgery. So we had a minimum of 2 weeks of them taking part in these activities here, or up to 15 weeks. The WestFit was delivered at the UHS for Wessex Cancer Alliance on behalf of the Hampshire and Isle of Wight STPs, and it was funded by part of the transformation bid. And incidentally, we were winners, the team were winners of the HSJ Cancer Care of the Year Award in 2020, which is quite a significant achievement. And as I said, it's a randomized controlled trial. And as Tom, as he alluded to, being fitter for surgery gives you better outcomes and reduced length of stay and quality of life. So the sites that were opened for WestFit were Southampton, Bournemouth, and QA Hospital in Portsmouth. And then we were recruiting very well and everything was going fine. And then COVID happened. And when COVID happened, our lives were turned upside down, as we all know. gyms and wellbeing centres were closed. The cancer patients were told to shield. Non-essential work stopped in hospitals. Cancer treatments were disrupted. Surgeries were cancelled or delayed, and all non-COVID research was stopped in hospitals. So we had active patients on our Westfit trial. We had to phone them, tell them we couldn't continue with the trial. Obviously they were devastated because of all of the above we've just mentioned. And our chief investigator for Westfit, Professor Sandy Jack, is also the chief investigator for SafeFit. This didn't sit well with her, so we were sad about what had happened. So we contacted Macmillan and also Can Rehab Trust to work on another trial. What can we do for these patients at this time, you know, this sort of time when all our lives were turned upside down? So that was on the 1st of April. So Westfit stopped on the 26th of March to recruitment. On the 1st of April, Professor Sandy Jack contacted Macmillan. On the 13th of May, the trial protocol was written. 20th of May, we have ethics, HRA, UHS as a sponsor gave the green light, and we recruited our first participant to SafeFit on the 29th of May. That was 8 weeks. Most clinical trials or trials take about 18 months to get to that point. So that was pretty impressive there. So the SafeFit protocol was in collaboration with all of these people that you can, these groups that you can see on the screen. So we're thankful for them for their input and the support to get us where we've got to. So what is SafeFit? It's USBP, sorry, is a self-referral clinical trial. It's not known in the country to be any other self-referral clinical trial, so participants refer themselves to this trial, and it was set up in response to COVID-19 pandemic. It provides cancer patients with exercise, nutritional and emotional support and advice in a virtual setting. The uniqueness is it's pandemic proof because it's in a virtual setting, and participants are on trial for a 6-month period on active trial with a 6-month follow-up. And it's delivered individually by telephone consultation or through Zoom, one-to-one online sessions. So, so what are the interventions? So they're like a holistic approach, as if you want to. So there's exercise, emotional support, and nutritional support. And I must emphasise the cancer exercise specialists that work on the trial are in collaboration with Can Rehab Trust, are exercise specialists that have additional training in healthy conversation skills, and they have undertake GCP and trial training, and they deliver the interventions. They're not psychologists and they're not dietitians, so they offer emotional and nutritional support along with the exercise part. So participants can choose to have all 3 elements depending on what their goals are, and or a combination of exercise and emotional support or nutritional support. It's all about the participant and what their goals and their needs are. So this is how the protocol or the participant experiences the SafeFit trial. So they self-refer through the website or they're referred by a clinician. And so they receive 2 emails. One contains a patient information sheet and then another one confirming a date and a time of a telephone screening appointment. So they have to take a screening appointment with one of our team, and then they provide consent, move on to baseline questionnaires, and then eventually match with an instructor to start their interventions. The sessions are broken down in this kind of format. For 6 months, they have 1 to 3 sessions per week for 1 to 4 weeks. And then they drop down to 1 session per week in weeks 5 to 12, and 1 session per month in months 4, 5, and 6. And we hope they get to the point of the 4th month that they feel more confident to be able to maintain or manage their own goals and keep to their session, keep doing their exercise or their nutritional, improving their mental, emotional health. So the participants receive a maximum of 23 sessions as part of the trial. So recruitment and funding. So the recruitment target for this trial is 1,100. It's quite a large trial sample size. So phase 1 of the trial was funded by Macmillan, and that supported 125 participants in the initial stage. Unfortunately, that funding ran out, and because of the climate we were in, and obviously, you know, yourself, planets as well, it's struggling to get additional funding to support these patients. So we had some matched funding from the UHS, which we topped up, and while we were doing that, we were putting in grants for the National Lottery, and also applying for NHS excess treatment costs. Because there was a gap in there, we had to stop recruiting for a while during that time while we were trying to find additional funding. So between August and December, this is when we're looking for extra funding for this, and we actually brought the governance of the trial into the UHS. So we actually lead the trial, and then we partner with Cairn Rehab Trust. So we opened the portal in December 2020, and then effectively this was phase 2. So this is a graph of our recruitment. So as you can see, in December, on the phase 1, we had 125 people recruited. The red line is our target recruitment, and the blue line is actually how we recruited. You can see how busy we were at that point. And this is some more metrics on our recruitment. So this is of the 10th of November. We'd consented 904 participants, so we're very close to target. We've registered on our database, which is 150 participants, but not all of them have gone through to be consent. They've dropped out for whatever reason, not completed the consent form or not completed the baseline questionnaires. So the referrals we had in phase 1 was 196. The number of referrals we've received in 1 and 2 is 1,802. And if you imagine they're self-referrals, these people are self-referring themselves to our system. The average waiting time for a screening appointment has risen to 54 days. I've highlighted that in yellow because I'll explain a bit more about that after we've at the end of this. So the team have completed 1,202 screening calls. We've got 4 whole-time equivalent members of the team, so that's quite a task and quite a lot of manpower to do that. So with people that have withdrawn pre-intervention is 36, post-intervention is 52, lost to follow-up is 10. So we have questionnaires again at 3 months, 6 months and 12 months, and at 12 months is our primary outcome of if there's been any change in people's behaviour, basically looking after, you know, sort of continue with the exercise and continue with the emotional support, you know, and just feeling better in themselves. So this is some lovely feedback we've received from our participants. I'll just leave that on the screen for a few seconds so you could read that through. And some more feedback here. And this has been the permission to share these publicly. So what we did not anticipate when we opened this trial was the speed of the referrals. So we're experiencing about 20 plus referrals a day, with a team of 4. The volume of referrals and so many participants, and we didn't realise how many people would need support. So to give you an overview, between December and March, December 2020 and March 2021, we received 844 referrals. Because it was self-referral, we didn't anticipate the treatment pathways we would experience. Because of like Westfit trial, we were looking at non-adjuvant and people waiting for surgery. We get referrals from people non-adjuvant or waiting for surgery and adjuvant, follow-up, palliative, radical and surveillance. So there's a lot of different treatment pathways. And because of these participants in different journeys from their on their cancer journeys, we were receiving quite a lot of referrals that people have quite complex comorbidities. So because SAFEIT is virtual, the safety is our paramount importance for our participants. So we set up a clinical advisory group because a lot of cases we need a clinical sign-off for these participants to be able to, for their clinicians to say they were safe to exercise, or with any modifications or any caveats to that. And our referrals to be on the trial is anybody over the age of 18 with a cancer diagnosis and have had their cancer as part of cancer treatment as part of NHS care. So to recap, from referral to matching, so referrals completed via our website, which is up there. They would have received a patient information sheet, had a full telephone screening assessment call with a member of staff, had the opportunity to ask questions, which is very important for informed consent, signed the consent form, completed the baseline questionnaire pack. And once that's all done, we're able to match them with a cancer access specialist and hand them over for their intervention stage. So for the future, when I highlighted the 54 days to screening, at the moment we've temporarily paused the referral portal while we try and catch up with these people. So it's a long time to wait from being referred into having an initial telephone appointment. So we're looking at opening the portal again in January to complete our recruitment phase. We're also in the stages of hopefully opening up a Wessex Safe Fit pilot service at the trust there in collaboration with Wessex Cancer Alliance. There's also an NIHR HTA grant called Pre-Op Fit, which is at second stage, and we're just waiting now. So this will be very similar to WestFit and SafeFit in another trial, and ImmunoFit as well, looking at exercise in participants who are taking on immunotherapy. So that's a whistle-stop tour. Sorry for rambling on. So I'd just like some acknowledgements of our partners and the government and national authority for their funding sources. So thank you very much. Any questions?
Thank you, Leslie. So the main thing is that, oh, someone has asked a question. So
okay.
Look, so the person that's raised their hand, do you want to pop your question into the chat?
So I stop sharing, I might be able to see. Can't see the question at the moment.
Look, a question hasn't popped up. Let me just have a look. So I've just allowed you to talk, John, if you wanted to ask the question.
Can you hear me?
We can.
Yes.
Fine. Thank you very much, Leslie, for your presentation. I'm one of Mr. Pearce's ongoing patients, but I was interested in what you were saying there. Is this facility available on the island? Because that's where I live.
It's a UK-wide trial, which I neglected to mention that. So it's open to anyone in the UK. So we have referrals from the Isle of Wight to the Outer Hebrides. So yes, right, it is available.
Do people in these outside reaches have to travel for this?
No, it's all virtual. That's the because of the pandemic and everything closing, we went virtual. So this trial is all virtual. So you just need to have be able to self-refer, so have access to the internet. So the sessions are delivered either through telephone or through Zoom if you have sort of that capability. So there's no traveling involved.
Okay, I think you've answered that question for me. Thank you very much indeed.
You're welcome. So because we've closed the portal, but if any of the clinicians that are on here or any patients that are interested in SafeFit, is still very much active in the background. So I can put on here later on our email address if anyone wants to email us over if they're interested.
Yes, that's very good. Thank you very much indeed.
You're welcome.
Thanks, John.
Thanks, Joanne.
So we've also got a question from Stuart. I've just turned your mic on, hopefully, Stuart.
Can you hear me now?
We can.
Yes, can.
Well, I was involved with SafeFit, and I am an ex-PE teacher, and I thought it was absolutely fabulous.
Oh, thank you, John.
It was delivered at exactly the right, in exactly the right way. I also had some experience through my wife of attending post-operative heart classes, and they were run very much along those lines. So it was, I never felt in any way pressured at all. It was, and mine, I was going to say instructor, but we still correspond, even though I'm now off the trial. We still email each other. And she was actually in Glasgow, and I'm on the outskirts of Portsmouth. So it was
incredible, isn't it?
A win-win situation. I just wish that it could be rolled out as on a much wider basis.
I think our primary outcome is, is that we would like to gather the evidence to enable this to become an NHS service available to everybody. And I'm sorry I called you John and it was Stuart. Big apologies. Yeah, so thank you for those really, really kind, positive words.
Well, it really was a fantastic experience. I was very disappointed when it finished.
Yeah. Oh.
Thanks, Stuart.
Thank you, Stuart.
It's great to hear about someone's experience. I don't think there's many downsides to getting fit and active, especially when you're a NET patient with all the different treatments we have to go through.
It's so important, and it's getting more and more important for these people to try and get as fit as possible. For surgery is it's challenging surgery, and I think a lot of them say you wouldn't run a marathon without doing a bit of training first. So
absolutely. Yeah. And also I think mentally it gives you some sense of control, like you're doing something proactive, so it puts you in a better place to deal with it.
You're taking control back of something that you don't really have any control over, so that's really good. And between sort of waiting for surgery or having treatment, you've got your mind, you've got a lot of time to think, haven't you? So this is very, very positive.
Thank you both for your questions. Has anyone else got any questions for Leslie? Otherwise we're just going to move into a general Q&A session. So pop any questions into the Q&A, or you can talk like John and Stuart just have as well. You just need to raise your hand. So there was a question earlier which Neil you might want to answer, so I will ask you to unmute. So someone asked earlier, what are the differences in the way we treat NETs in the bone? So I guess we've talked about lots of different types of treatment, and how would they relate to sort of a bone mets, I guess.
Bone metastases are potentially awkward. We can't target them quite as easily as we can many other secondary sites. But we do still have a range of treatments. So it really depends on the context of the bone metastases. Occasionally you get somebody who's got a solitary deposit and they don't have any other metastases anywhere else. Under those circumstances, it depends on the size of the deposit and the exact location. Depends if it's about to press on anything, but we can use conventional radiotherapy, so external beam radiotherapy, or we can put probes into solitary deposits and freeze them, so cryoablation. And both of those can be effective treatments for solitary deposits. They're a little bit limited by structures that are the deposit may be adjacent to, but they're good for controlling symptoms like pain, and they can prevent progression and prevent tumors moving to the extent where they, say, press on the spinal cord or something like that. Then we've got Other treatments like Zia's PRRT, which is a form of targeted treatment, has been described, but it's a systemic delivery. So you give it to the whole body, but it then targets the individual tumor sites. And that can be very good for bone metastases. And for people with lots of bone metastases, that would usually be our preferred treatment. But it does depend what receptors you've got and how positive your various scans are, because Zia wants a good target. You want something that's going to light up well, suck up the right molecules so that the radiation is delivered to the tumors and isn't just wasted around the rest of your body. And then we've got chemotherapy. So systemic chemotherapy in all its different forms treats tumors wherever they may be across the body. So if that includes bone sites, then your chemotherapy will usually be as effective for bone metastases as it is for tumor deposits anywhere else. So chemotherapy comes in many different forms. We've got biological agents such as, your most basic biological manipulations, the hormonal treatments such as somatostatin analogs. And they can, so that's your depot monthly injections. And that can be effective in slowing down rate of progression of disease within bones. If your tumors are more biologically active, so they're growing faster, then conventional chemotherapies are more effective. But we also have other biological agents such as everolimus and sunitinib, which can be used for patients with bone secondaries whose tumors aren't behaving quite so aggressively. So there's an awful lot of options. There's always a lot of options in neuroendocrine. And it really depends on pattern of disease. Is it solitary? Do you have symptoms? Where else have you got disease? How fast is it growing? How fit are you? What kind of receptors has it got on it? So there's a lot of questions, and that's why we're fortunate enough to have multidisciplinary discussions for every patient. At the end of the day, there isn't a sort of one-size-fits-all answer. Planets and our team approach at the Wessex NET group is all about trying to find a bespoke solution for you, make sure that we've had input from all the different specialists and put the whole picture together, then discuss the options with you and see what we go for. Does that answer it?
Very good, thank you, Neil. Has anyone else got any questions? We've had lots of questions throughout the day, so we might not get too many at the end, but if you've got a question, we've got Neil on tap here, so make the most of it. No questions coming through at the moment. You can also raise your hand and talk if that's easier than typing for some of you. So this has been recorded. I've said this already, but this has been recorded. So if you do want to have a little look through again, because there's a lot of information to take in one day, then just get in touch with us and we can ask any questions for you. Hope you've found it. Oh, hang on. We've got another question from Stuart. Is anything being looked at regarding NETs and aging? Do you mean, Stuart, with regards to, is NETs part of aging, or?
Does it make you age? I hope not.
I'm not aware of any specific age-related or aging-related studies. I'm part of the NCRI trials group for neuroendocrine tumors. So I get to hear about different studies that we're looking at developing and that are coming through. And I've never, in the 10 years I've been part of that group, seen anything associated with aging from any aspect. That would be quite an unusual kind of approach to a study for any cancer group. I don't know if Jocelyn or Leslie have anything else specifically to offer on that, but it's not a typical question. We tend to try and be not very ageist in the way that we approach these studies. Neuroendocrine tumors, I've operated on patients from sort of 8 to 98 with neuroendocrine disease, and we do try and avoid being ageist, really. We try to be inclusive.
No, if I may add as well, Joe, yes, the question I'm not clarified, but I would try to. Our youngest patient with regards to NET in pediatric age group has been 4 that we have treated. It's known as the neuroblastoma with the PRRT. And as far as 86 years of age, we have included in PRRT. That is just one aspect of it. As Neil has alluded, the rest of the components.
So Stuart, to ask that question, I think I'm just going to unmute you because you've got your hand up. Did you want to add anything?
Yeah, it wasn't. I wasn't trying to be ageist. It's just that as I get older, and I find that the problems of aging, trying to differentiate whether it's actually me getting older or sorry.
You're playing your guitar at the same time.
Very impressive.
Apologies for that. If I can regain my thread. As I get older, I sometimes wonder, is the problem that I may experience actually to do with aging, or is it to do with my NETs? That's really what, and I find it, obviously times are awkward at the moment, but trying to get into the primary area for with my GPs, trying to get over to them that there may be a problem, I find a little bit frustrating. It was from that area that I was approaching it. Perhaps I've not made myself.
Yeah, no, you've made yourself clear, Stuart. Thank you. And I think it is always difficult with the older population to establish whether new symptoms are related just to the natural aging process, or whether they're related to disease progression, or whether they're related to treatment side effects. And it can be really hard to differentiate. And I think having a good relationship between clinicians and patients often is really helpful. And I'm very reliant on Emma and the CNS team to say to me, actually, Stuart's not right, or whatever. I mean, she hasn't actually said that to me, don't worry. But I am reliant on that kind of having a continuity of relationship so that you can really help unpick what is neuroendocrine and what's life. Because at the end of the day, we're all aging. Our DNA is getting older and less reliable. And just because you've got neuroendocrine tumor doesn't mean you can't get something else. So, we always have to think, could it be a totally different disease process? Could it be the new bowel symptoms aren't related to Carcinoid syndrome or previous surgery, or could they be due to you having a tumor in the bowel or diverticular disease or something else? So we do have to keep an open mind with patients that we're having a very long-term relationship with. You know, if you're only being followed up for a few months, the likelihood of another disease cropping up is pretty small. But if you're a neuroendocrine patient and we want to keep you going for 10 or 20 years, then it's entirely reasonable to expect you to get other conditions during that time. And it can be very hard to unpick.
Yeah, thank you. I'll have to keep dodging and weaving then.
Yeah, and so on. And keep up the guitar work. It's very impressive. Use you at the next Planet's Ball, Stuart Hendricks. John, is that a new hand or is that a legacy hand?
So are you talking to me, Mr. Pierce?
John, we've got your hand up. Did you want to ask another question?
Yes, well, I was just going to say that following from what that gentleman was saying, I've been a patient over at the NETs at Southampton for 20 years. And I was a fairly young man when I started, and I'm fine. And that's all due to the incredible work of the team. It's new for me to actually connect with one of these video conferences, but I think everybody's done a wonderful job. And I'd just like to say to your last gentleman, I'm now 80 coming this next year, and I've been doing very well, and that's all due to your input as well. So I wish you all the very best, all of you. Thank you very much.
Another 20 years in you, John.
Yeah.
Thanks, John.
Most probably not another 20 years, but
You have. So
Yeah.
stay fit and not get something else.
no, it's brilliant. Anyway, thank you very much, all of you.
So we've got another question just down the side here, actually. It says, general question. I'm having my first liver embolization on Tuesday. I understand the theory. Any hints before or after from anyone who's had or done it?
Ooh.
Layla and Neil.
Oh. Any advice? Is it stay overnight? I can't remember. My treatment's all merged. Is it stay overnight?
Entirely variable.
Yeah.
Some people are staying 2 or 3 nights if they've got heavy carcinoid syndrome. Other patients, usually just 1 night would be a typical thing. But it depends how much we're embolizing. Depends on your situation. If you've got carcinoid syndrome, you'll be in for a while. If you don't have carcinoid syndrome, it might be a faster turnaround. But it depends how you are afterwards. Some people get a lot of discomfort. Other people get virtually none. So, it really is hugely variable. You don't know until you've had your first one, really.
No.
And your experience with one may be totally different to your experience the next time around. So, they might embolize you quite hard the first time because they're aiming for some big deposits, say. So that might leave you feeling quite washed out, might give you quite a lot of discomfort under the ribs, kind of pain that catches you when you take a breath in. Or it might be that your first embolization, they're going gently for some reason, and they're only targeting some small deposits on one side of the liver, in which case you might hardly turn a hair. So there is a huge range of experiences with embolization, which I think Emma will agree with. Emma probably sees this in person more than anybody else.
Oh, yeah. So I think you're right, Neil. It's everyone has totally different experiences, and like you said, from one embolization to the next, you might be, have quite a lot of post-embolic syndrome the first time round, you know, sort of quite flu-like symptoms, quite under the weather, off your food, you know, just not being able to do very much for a couple of weeks, and then the next time you will fly through and wonder, you know, if they've ever even done anything. So it's very much wait and see. But what I would advise is don't plan anything for the week or two after the embolization, just so you know that you can rest if you need to. Yeah, and then you can just plan things if you're feeling better.
I think from a personal experience, I was very fortunate. I've had a few times embolization now, and I literally don't really feel like I've had anything done to me. I was very fortunate. I had a couple of weeks off, booked a couple of weeks off, but I really didn't have any post-procedure symptoms. I think, I don't know, do normally people be put to sleep now, Emma, or is it's no? So yeah, so I think when you're there, I think you can panic because you're going into this room that is a theatre, and you can watch it all. Personally, I found that really exciting, and I loved watching it all. And I really enjoyed it, but it's quite daunting because it is that theatre environment, and it's all a bit like that scene in E.T. where they're all, you know, masked up, and it's so I think it's each to their own. You either really enjoy it or you don't. So if you don't enjoy that kind of thing, it's just a case of just keeping calm and breathing. And the only other advice I can give is when you're in hospital at any point, any procedure overnight, take some headphones and some top cap sleeping mask, because it really does help to try and get some sleep because you don't really get much sleep in hospital. So anything that, you know, a bit of whale music or waves, that is essential for me, because I think the sleep really helps you to recover. And I think a lot of people underestimate the importance of getting to sleep properly when you've had any procedure when you're in hospital.
So I don't know whether John has got his hand up again. John, I will ask you to unmute. I'm not sure whether that's from before or whether you've got another question.
Sorry, I've got no more questions. Okay. I just like this. I said that, you know, I think this video view this morning was fantastic. And I just thank everybody, all the teams that have been involved in Southampton and on the South Coast for all their support. And I've actually had plenty of that. So thank you all very, very much.
Thank you, John. And thanks everyone for joining. I've got any more questions? We've all been sat still for quite a long time, but I think we've all had the opportunity to listen to lots of interesting information and may have some questions later, and just send them over to us. That's what we're here for. Anyone else got anything to add? Layla or Emma?
Just thanks everybody for coming along and listening. Hopefully we'll see you in 2022 on a more face-to-face basis. Let's keep our fingers crossed, I think.
Yeah, so we will, as Layla mentioned at the beginning, we've got that Facebook group where we share lots of things. So if anyone wanted to join that, then you can ask questions in there, and I will also post this presentation today. Will all be on there, so you can watch it all again. And people that weren't able to join, there's quite a few people that couldn't make it. They have the opportunity to watch it at a later date. And we will also put out the coffee morning that we're going to do in January, which we're going to do at Maggie's in Southampton, which is on the UHS site. If you haven't been there before, it's a really nice place. So we're going to get that sorted. So look out for the date for that. Possibly a Wednesday afternoon. That's when they thought they could accommodate us, but I will share details of that. And anything else, just get in touch. Thanks everyone for joining, and thanks for staying on for the Q&A. And lovely to see you, Neil. That was a nice surprise this morning. I think everyone's glad to see your face.
Yeah, well, better than where I was last week. Because I was still on intensive care. So there we go. but I'm
You're all
good.
now. That's all that
Alive and kicking.
Thank God.
Yeah, a little bit croaky.
Brain's still functioning though. That's the main thing. Thanks for bringing the.
And the rest didn't function anyway, so it doesn't matter. So.
Okay. All right. Well, we'll end the meeting there. Thanks very much, everyone. Thanks for joining us, and we will hopefully see you in person very soon.
Thanks all. Bye.
Bye.
Bye.